Hello everyone. So I am Biswanath and today let's start with the chapter that is abdomen. Okay, and this is the part 3 of your anatomy marathon. If you haven't watched the parts 1 and 2, the part 1 that has your upper limb, lower limb and your genetics, and the part 2 has your pelvis in detail. Let's discuss about the abdomen. Okay, let's discuss about the abdomen today. So abdomen is a very interesting topic and is a, just a little bit longer topic. Okay, so what are the important landmarks of the abdomen? Okay, so we have the xiphoid process here, the 7th rib here, 8th rib, 9th rib, 10th rib, the subcostal margin, okay, the iliac crest, your iliopubic eminence, your ASIS, that is your anterior superior iliac spine, which contains your which gives attachment to inguinal ligament as well as the sartorius muscle. Okay, and your AIIS, that is your anterior inferior iliac spine, which gives origin to your rectus femoris muscle, and this is the superior ramus of the pubis. Okay, this the superior ramus of the pubis, there is a line. Okay, there's a line which is the superior ramus is connecting. Okay, the line which is connecting to the pubic tubercle to the iliopubic eminence. This is the iliopubic eminence and this is a pubic tubercle. This line is called as a pectineal line. Okay, your greater sciatic notch, lesser sciatic notch, your sacrum is there, L5 vertebrae is there, your ala of sacrum, this part is called as the ala of the sacrum, this part. Okay, the obturator nerves passes just lateral to the ala of the sacrum, you know this, okay, from our lower limb discussion, and you have the pubic symphysis in this manner. Okay, so talking about this, talking about the planes. Okay, in the upper border of T9 we have our xiphoid process. Xiphoid process lies in the upper border of T9. Okay, then we have our this divisions. Okay, and T10, T11, T12, L1. So lower border of L1 we have a transpyloric plane at the lower border of L1. At the lower border of L2 we have a subcostal plane or transpyloric plane, subcostal plane. Okay, umbilicus is present between L3 and L4. We'll discuss more about umbilicus later. Okay, and the lower border of L4, in the lower border of L4 we have supracrystal plane. This is connecting the high points of the iliac crest. The iliac crest is present like this. Okay, it is connecting the high points of the iliac crest, the supracrystal plane. And at the upper border of L5, we have a transtubercular plane, which is also called as the intertubercular plane. This is a line connecting the tubercles of the iliac crest. Okay, so the supracrystal plane at the lower border and the transtubercular plane L5 at the upper border of L5. Lower border of L1, that is transpyloric, lower border of L2 subcostal, lower border of L4, that is supracrystal, and the upper border of L5, that is transtubercular plane. Let's discuss the quadrants with the right upper quadrant, the left upper quadrant, right lower and the left lower quadrant. Okay, talking about regions, we have about 9 regions. Okay, so what is the region? This is the diaphragm. So this region is the epigastric region. This is the right hypochondrium, the left hypochondrium. Okay, then you have the transpyloric plane. This transpyloric plane was lying in the lower border. This is the lower border of L1. Okay, so this is the lower border of L1. Below which it is the umbilical plane, the umbilical region. This is a right lumbar region, this left lumbar region. Then you have the transtubercular plane, which is passing from the upper border of T5 of your L5. Sorry, so this is the transtubercular plane passing at the upper border of L5. Okay, so this is the plane, and then we have below it we have the right iliac fossa, the left iliac fossa, and the hypogastric region. The skin of the anterior abdominal wall has increased stretching capacity. And what are linear albicanthus? These are whitish streaks in the skin of the lower abdominal wall due to pregnancy. Okay, understood? So this is about your planes and the regions of the abdomen. Let's move on. So now we are into the anterior abdominal wall. Okay, anterior abdominal wall. First let's discuss the umbilicus, which is very important. It's a remnant of the umbilical cord. Level is a L3 to L4 level. Between the level of L3 and L4, okay, it is lower position in infants and person in pendulous abdomen. It is a bit lower, like L4 level. Okay, dermatome is a T10 dermatome, called as the watershed area, because the lymph is draining into the lymph nodes. You will see it's the site of a portocaval anastomosis. Okay, so this is the umbilicus. This whole part is umbilicus. If this is umbilicus, we have an umbilical artery, two umbilical artery, which will carry deoxygenated blood, and you have the one umbilical vein which will carry that oxygenated blood. Okay, so if this is the projection which is called as the vitelo-intestinal duct. If there is persistence of your whole vitelo-intestinal duct, it will cause cherry red tumor. Okay, and if there is the persistence of the proximal part of the vitelo-intestinal duct, okay, if it persists, it will be called as the Meckel's diverticulum. And if the distal part it will persist, okay, the distal part, if it persists, it will call as the enterocele. if it is persist, it's called as the enterocele. Okay, and this projection is called as allantois, and this allantois is obliterated allantois is called as the urachus, and this urachus gives rise to a median umbilical ligament. Just remember from previous discussion we were discussing the pelvis. Okay, and this is urinary bladder. We had the ligament that is connecting to the umbilicus to the urinary bladder, that is a median umbilical ligament. That's a median umbilical ligament. Okay, so this urachus is giving rise to the median umbilical ligament, and if this median umbilical ligament persists, if it remains patent or persists, it is called as a urinary fistula. Okay, which is called as a weeping umbilical cord. Okay, like the umbilical cord will weep, okay, due to the leakage of urine. Okay, understood. And these parts are there, and if the persistence of whole vitreointestinal duct is there, it is called as a fecal fistula. Whole vitreointestinal duct, if it persists, okay, it will be called as your fecal fistula, where cherry red tumor is seen. Understood. So this is all about okay, we have the two medial umbilical ligaments, which are remnant of the distal part of the umbilical artery. Okay, so this is about the things, and this is the umbilicus, median umbilical ligaments, medial umbilical ligament, one medial umbilical ligament. Okay, we have the lateral umbilical folds also, lateral umbilical folds. Okay, and the lateral umbilical folds is the inferior epigastric vessel held within the peritoneal fold. Okay, if the inferior epigastric vessel held within the peritoneal fold will cause a fold in the anterior abdominal wall, which is called as the lateral umbilical fold. Okay, and caput medusae, what is caput medusae? The portocaval anastomosis, which open up to form dilated radiating veins, like here is umbilicus. Okay, so it will form veins like this will call the caput medusae. Okay, caput medusae, and the cause of formation is the portocaval hypertension. Okay, portal hypertension. Due to portal hypertension, your caput medusae may be formed. What is the embryological importance of umbilicus? It's the meeting point of four folds of embryonic plate. It is the meeting point of three systems, like a digestive system, that is the vitreointestinal duct is the digestive system, the excretory system, urachus is the excretory system, and the vascular system, the umbilical vessels are there. Okay, so it is the embryologically important. Okay, so finishing the umbilicus, let's move on to the next concept. So let's discuss the layers and the muscles of anterior abdominal wall. So anterior abdominal wall has about 8 layers. 8 layers are there. First, of course, it will be skin, superficial fascia. The superficial fascia is divided into two parts, that is the campus fascia and scarpa fascia. This campus fascia is the outer layer and it is the fatty layer, and the scarpa fascia is the inner layer and the membranous layer. Okay, there is no deep fascia in the anterior abdominal wall, very important. And in which other region there is no deep fascia present? In your skin. Yes, in your skin there is no deep fascia present, but exception is there in your in your face. Okay, not in your skin, what I'm saying, in your face there is no deep fascia present. Okay, and what is the exception? That you have a deep fascia present in the parotid gland. Okay, then we have the external oblique muscle, internal oblique muscle, transverse abdominis muscle, fascia transversalis, below that transverse abdominis. Okay, extraperitoneal connective tissue and the parietal peritoneum. Okay, campus fascia will continue in the scrotum, which will call as the dartos muscle. Remember, we discussed the structures in our pelvis discussion. The scarpus fascia continues in the peritoneum, which is called as the Colles fascia. Let's discuss this. Okay, this is the scarpus fascia. If it continues in the peritoneum, it will be called as a Colles fascia. Okay, this is the continuation of the scarpus fascia in your peritoneum, will be called as a Colles fascia. Okay, then if your campus fascia continues in the scrotum and is called as the dartos muscle. Okay, this dartos muscle is the continuation of your campus fascia. Okay, this is your genital diaphragm, and you know about this, the deep perineal pouch, superficial perineal pouch and all. Okay, and this carpus fascia, this extends beyond your inguinal ligament till the Holden's line. What is the Holden's line? The fusion of fascia lata and the scarpus fascia. It is the fusion point of fascia lata and the scarpus fascia. It is called as the Holden's line. Okay, talking about this, we have this part, we are discussing this part. Okay, and this is covered as scarpus fascia. This is the Holden's line, is this one is the Holden's line. The Holden's line, it is fusing, the scarpus fascia is fusing the fascia lata. This red part is the fascia lata. Okay, the point of fusion is called as the Holden's line. This is the inguinal line. What is the neurovascular supply to the anterior abdominal wall? So we have this anterior abdominal wall. So what is the neurovascular supply? Okay, First of all, we have our superior epigastric arteries that are supplying here, okay, and we have our posterior intercostal arteries from your aorta, posterior intercostal arteries, so supplying the lateral parts of the anterior abdominal wall, okay, and then from the femoral artery, we will have a branch that is a superficial epigastric artery, which will also supply it, superficial epigastric artery, okay, and your external iliac artery, which will arise from your femoral artery, and this branch, okay, this external iliac artery, this is external iliac artery, and continues the femoral artery, okay, and this artery, the external iliac artery, will give a branch which is called the inferior epigastric artery. This inferior epigastric artery and the superior epigastric artery fuse at the level of your umbilicus, okay. So this is your neurovascular supply to the anterior abdominal wall. Let's talk about the venous drainage. So we have your axillary vein here, okay, and this axillary vein, we have the lateral thoracic vein. This axillary vein continues the lateral thoracic vein and the superior epigastric veins also, okay. So this is draining into this part and this is draining into this part, okay, superior epigastric veins, and this is draining into axillary vein. So this axillary vein and your superficial epigastric vein, okay. These are there. And about lymph nodes, we have the axillary lymph nodes. This lymph from here is draining into axillary lymph nodes like this, and lymph from this lower part is draining into your superficial inguinal lymph nodes, okay. So this umbilicus region is called as a watershed area because the lymph and the veins are draining like this, as a watershed, as a fountain, okay. What are the muscles of the anterior abdominal wall? So we have the external oblique muscle. The origin of the external oblique muscle will have the 8 slips. It has origin from 8 slips from the lower 8 ribs, okay. The origin is from the lower 8 ribs, okay, and this upper 4 slips interdigitate your serratus anterior also. This upper slips, okay, it interdigitate with your and serratus anterior muscle also, and lower 4 slips will interdigitate with your latissimus dorsi, okay. These are the lower 4 slips that will interdigitate with the latissimus dorsi, this part, okay, and the upper four slips will interdigitate with the serratus anterior, okay. What is the insertion? See at the insertion, okay. So we have a iliac crest here. This is the iliac crest. So anterior 2/3 of the iliac crest will be the attachment, okay. Your inguinal ligament will be the attachment, okay. Inguinal ligament, your pubic symphysis, pubic tubercle, okay, and your ASIS. So these are your attachments, okay. So these are your attachments of your external oblique muscle, okay. Understood? So external oblique muscle has fleshy fibers. These are the fleshy fibers of external oblique muscle, okay. And then these are aponeurotic fibers. These are the aponeurotic fibers of external oblique muscle, okay. So nerve supply, what is the nerve supply? T7 to T11, okay. This is supplying the thoracoabdominal nerve, okay. T12, that is the subcostal nerve. This both nerves, thoracoabdominal and the subcostal nerve, are from the ventral rami of these nerves are supplying the external oblique muscle, T7, T11 and the T12, okay. And then the external oblique muscle, internal oblique muscle, nerve supplies again T7 to T12 and L1 nerve, okay. T7 to T11 it was there, okay. Here it is T7 to T12 and not T12, L1 nerve, okay. Talking about this, what is the insertion or the origin? It originates from below and moves up, okay. The origin from your thoracolumbar fascia. This is the thoracolumbar fascia, okay, and the anterior 2/3 of the iliac crest, thoracolumbar fascia, anterior 2/3 of the iliac crest, okay, and the lateral 2/3 of the inguinal ligament, it originates from here, okay, and also from your pubic crest and the pectineal line. You can write this also, okay. And this is also your fleshy fibers and your aponeurotic fibers, like this, okay. So I am denoting the fleshy fibers in this orange part, okay. So this attaches to the xiphoid process, to the linea alba, okay, to the xiphoid process, and again to the fleshy fibers insert to the 3 to 4 costal cartilages, interdigitate in the 3 to 4 costal cartilages, okay. This is the attachment. Understood? So let's discuss about the transverse abdominis. This is a transverse abdominis, or a transverse abdominis, whatever you can say. Origin is from inner surface of lower 6 cartilage, so lower 6 costal cartilages, like to 7 to 10 costal cartilages, thoracolumbar fascia, anterior 2/3 of your iliac crest, okay, inner lip, and the lateral 1/3 of the inguinal ligament, okay. Insertion is to the xiphoid process, linea alba, pubic crest, and the pectineal line, okay. And this aponeurosis of the internal oblique and the transverse abdominis is fused and form a tendon which is called as a conjoint tendon. So what forms a conjoint tendon? This conjoint tendon is formed by your internal oblique muscle, okay, and your transverse abdominis, IOM and TA will form your conjoint tendon. Understood? So and the nerve supply is T7 to T12 and L1, just like our internal oblique muscles. The transverse abdominis, the nerve supply is T7 to T12, okay, T7 to T12 and your L1, okay, and for your internal oblique muscle it is again T7 to T12, okay, and your L1, okay, but the nerve supply to the internal oblique muscle, the external oblique muscle, this is T7 to T11 and your T12 is subcostal nerve, and this is the thoracolumbar nerve, thoracoabdominal nerve. So let's discuss about the incisions of the anterior abdominal wall. What are the incisions? What are incisions of the anterior abdominal wall? So we can have a midline incision. These are important in the surgery. Okay, in clinical is the integration of surgery. Okay, we have a suprapubic incision. This is a suprapubic incision. It's a right paramedian incision with muscle retraction. The muscles are retracted from here. Okay, then we can have subcostal incision just below the costal margin. You can have your gridiron. Okay, gridiron is called the McBurney incision. Okay, and then you can have a thoracoabdominal incision. This is thoracoabdominal incision. Okay, and the thoracoabdominal incision again this. Okay, and this is a paramedian incision with muscle splitting. This muscle is splitted. Okay, here it was retracted. Muscle retraction was there. Here we have split. Here was split, and the paramedian, and you can have your thoracoabdominal incisions also. Okay, so this completes your anterior abdominal wall, the layers and the muscles. Let's move on to the next part. Okay, two other muscles, that is your rectus abdominis and pyramidalis. Pyramidalis is a very small muscle. Main is the rectus abdominis. You must have seen your wrestlers, okay, having this kind of appearance. This is your rectus abdominis muscle. Okay, talking about the rectus abdominis, just a important fact is the linea alba will provide insertion to the external oblique, to the internal oblique, to the transverse abdominis, and also to the pyramidalis. Okay, but not to the rectus abdominis. Okay. So what is the origin point of this rectus abdominis? Originates from it originates from pubic crest. It has a lateral head which originates from the pubic crest. Okay, originates from the pubic crest, and the medial head originates more or less from the pubic symphysis. Okay, so origin is very easy. Lateral head from pubic crest and the medial head from pubic symphysis. It descends upward. The fibers will descend upward. It has tendinous intersections between them, and like tendinous intersection like here and here. Okay, and the fourth tendinous intersection, it is incomplete. Okay, this fourth tendinous intersection, it is incomplete. Just remember this. And how it is inserted? It is inserting in the fifth costal cartilage, sixth, seventh, and the xiphoid process. Okay, this is the insertion, the fifth to seventh costal cartilages and the xiphoid process. This is the insertion of a rectus abdominis. Okay, and this lateral border of rectus abdominis is called as a linea semilunaris. Okay, so this is the thing. And location is the most superficial core muscle. Okay, originates from the pubic crest. Okay, inserts into the xiphoid process and 5 to 7 costal cartilages. What is the action? Your trunk flexion. Okay, flexion, like we are bending over. It's called the trunk flexion and compresses the abdominal viscera during forced expiration and intense effort. What's the innervation? Your intercostal nerve and the subcostal nerve. Okay, the same insertion as the external oblique, the same innervation as the external oblique muscle. Let's talk about the pyramidalis muscle. Okay, talking about pyramidalis originates from the anterior surface of the body of the pubis, and inserts into a linea alba. We talked about that. Linea alba gives insertion to the pyramidalis even, and nerve supplies your T12 nerve. Okay, so we are done with the rectus abdominis and the pyramidalis. Let's move on to the next concept. Let's discuss the inguinal ligament. So inguinal ligament is also called as the Paupart's ligament. Okay, it is a modification of external oblique aponeurosis. Just pay attention. Okay, this is the linea alba. This is the pubic tubercle. Okay, and this is the ASIS. So ASIS from the ASIS to the pubic tubercle, you have the inguinal ligament. We also discussed this in our lower limb. What are the modifications? This inguinal ligament, it modifies in the transverse line, forms a pectineal ligament or the ligament of Cooper. Okay, we had this is not the suspensory ligament of Cooper. Remember, we had the suspensory ligament of Cooper in our breast. Okay, and the inguinal ligament, where it the inguinal ligament and the pectineal ligament, Okay, between these two we have our this type of lacuna form, so called a lacunar ligament or the ligament of Gimbernat. Okay, ligament of Gimbernat. Okay, so this is a ligament of Gimbernat. Okay, and here we have the reflected part of inguinal ligament, reflected part of inguinal ligament. Okay, so three modifications: ligament of Cooper, ligament of Gimbernat, and the reflected part of inguinal ligament. So this is all about the inguinal ligament. Let's talk about the rectus sheath. The rectus sheath is the aponeurotic sheath covering the rectus abdominis. Okay, we have the arcuate line or the linea semicircularis. Okay, linea semicircularis or the fold up dog glass. What is this? The lower border posterior wall of the rectus sheath is called as a arcuate line or the linea semicircularis or the fold up dog glass. Okay, so this is the arcuate line. This is the arcuate line, and the posterior part it is the posterior border of the posterior wall, okay, and this is the rectus abdominis must be there. Talking about this, we are taking the transverse section above the costal margin, okay, so this part above the costal margin, this is your costal margin, this is the costal margin, so we are taking transverse section above the costal margin. So what will observe the external oblique muscle, okay, and the EOA, that is external oblique aponeurosis, okay, and the RA, below it external oblique aponeurosis, we have the RA, that is the rectus abdominis, okay, and the 5, 6, 7 costal cartilages, okay, the external oblique, EOA, and the rectus abdominis below the external oblique aponeurosis, 5, 6, 7 costal cartilages that will form the posterior wall. Okay, if we take the transverse section between the costal margin and the arcuate line, between the costal margin and the arcuate line in two, this in this two, okay, this one, the second this, okay, so if you take this between the costal margin and the arcuate line, so we will see external oblique, internal oblique, and transverse abdominis. Okay, all three fascias are coming like this. The internal oblique, this aponeurosis of the internal oblique, this is dividing, okay, and it's all three, the transverse abdominis also, its faces covering like they're converging in the linea alba. Okay, and this fascia, the posterior lamina of internal oblique aponeurosis, okay, and the transverse abdominis aponeurosis, and the fascia transversalis. Okay, fascia transversalis is blue one. Okay, so the transverse abdominis aponeurosis, okay, and the fascia transversalis, this, and the posterior lamina of internal oblique aponeurosis, this three are forming a posterior wall, and the anterior wall you have your external oblique aponeurosis, okay, EOA, external oblique aponeurosis, and the anterior lamina of IOA, anterior lamina of internal oblique aponeurosis. Then we are taking transverse section below the arcuate line. What are those? Okay, if we take the transverse section below the arcuate line, this part, okay, below the arcuate line. So what will be present? EOA, external oblique, internal oblique, transverse abdominis. Okay, here the aponeurosis of this three muscles will there. Okay, and the external oblique aponeurosis, okay, and we have the aponeurosis of internal oblique and transverse abdominis, okay, which are combining. We said the internal oblique and transverse abdominis aponeurosis, they combine to form the conjoint tendon, and this external oblique aponeurosis plus the conjoint tendon will form an anterior wall, and posterior wall is formed by the fascia transversalis alone. Okay, what are the contents of the rectus sheath? So we have discussed the rectus sheath in this manner. Okay, we have discussed the rectus sheath, the sections at the level of the rectus sheath, and what are the contents of the rectus sheath? So we have two muscles, two vessels, and nerves. Okay, two muscles, two vessels, and two nerves. Your two muscles, what are the two muscles? Rectus abdominis and the pyramidalis, where rectus abdominis is the chief content. Two vessels, what are the two vessels? Superior epigastric and the inferior epigastric vessels. Okay, the superior epigastric vessel is the branch of internal thoracic artery, okay, and inferior epigastric vessels are the branch of your external iliac artery. Understood? And two nerves, your thoraco-abdominal nerve, that is the T7 to T11, and the subcostal nerve, that is T12. The function checks the bowing of your rectus muscle and strength of increase the strength of the anterior abdominal wall. Okay, so this is all about your rectus sheath. Talking about the inguinal canal, let's move on to the inguinal canal. Okay, inguinal ligament we discussed. Okay, rectus sheath we discussed. What is the inguinal canal? So we'll see the deep inguinal ring and superficial inguinal ring, which are very important. Okay, we'll take a transverse section and the sagittal section at the level of inguinal canal. Okay, and discuss about the contents. Okay, So you can get a short note on the inguinal canal. So it is 4 cm long. It is 4 cm long. What's the direction course? Downward, forward, and medially. Downward, forward, and medially. Downward, forward, and medially in this direction. In this direction. Okay, is lying, and we have this ASIS and your pubic tubercle. These are and between them you have your inguinal ligament. Okay, and you have 1.2 cm above the mid inguinal point. 1.2 cm above the mid inguinal point we have your DIR, that is a deep inguinal ring. Deep inguinal ring, which is present in your fascia transversalis. Okay, and then we have the superficial inguinal ring that is present in external oblique aponeurosis. External oblique aponeurosis. Okay, so from the mid inguinal point. Okay, so from the mid inguinal point, not mid inguinal point is not the midpoint of the inguinal canal of the inguinal ligament. Okay, it is like the midpoint and the mid inguinal point. Okay, it are different. They are different. Understood? So it is not the midpoint because it is connected to the pubic tubercle. Okay, if the mid inguinal point is the length, mid inguinal point, it is the length between your ASIS, between the ASIS midpoint of ASIS and pubic, not tubercle, symphysis, and the midpoint is between the ASIS and your pubic tubercle. Okay, don't get confused. Pubic tubercle, don't get confused. Okay, and this is a super deep inguinal ring and a superficial inguinal ring. Okay, as you are moving forward, so you are going to the superficial side. Okay, this is the diagram which you can correlate with this transverse section of the inguinal canal. What is the transverse section? If you take the transverse section of the inguinal canal, okay, this is the lateral side, this is the lateral side, this is the medial side, this is the posterior side, and this is the anterior side. Okay, so you have the deep inguinal ring, you have the superficial inguinal ring. Okay, and here you have the inguinal canal like this. So this is the inguinal canal. Understood? So what we have, like what I told, that transverse abdominis and internal oblique aponeurosis and external oblique aponeurosis. Let's try to connect. Okay, so you must have your deep inguinal. This is the first is the fascia transversalis. This is the fascia transversalis. Okay, fascia transversalis is forming a deep inguinal ring, as you wrote above. Okay, your fascia transversalis is forming a deep inguinal ring. Okay, deep inguinal ring. And this fascia there is a, then your conjoint tendon is there. Okay, your transverse abdominis is coming like this. Transverse abdominis, the tendon transverse abdominis will be like this and forming a conjoint tendon, and the internal oblique will be lying posterior to this inguinal ring. Okay, this inguinal canal. Okay, and will be forming a again contributing to the conjoint tendon. Okay, so in the posterior wall we have your fascia transversalis, your conjoint tendon. Okay, and some reflected part of your inguinal ligament also. Reflected part of inguinal ligament. That is a modification of the inguinal ligament. This one, reflected part of inguinal ligament. Okay, these are forming a posterior relation. So the posterior wall of your inguinal canal. Posterior wall of the inguinal canal. Okay. And then you must have your internal oblique muscle. Okay, internal oblique muscle and its aponeurosis. Not the aponeurosis will mainly contribute to your conjoint tendon, form a conjoint tendon. It's a posterior wall relation. Your internal oblique muscle, and external oblique aponeurosis, which will be present in the anterior wall. So internal oblique and external oblique aponeurosis will form your anterior wall. Understood? And this external oblique aponeurosis in this part will form a superficial inguinal ring. Understood? This anterior one in entire extent, external oblique aponeurosis is there, and towards the lateral side, internal oblique muscle is also there. And the posterior wall in entire extent, your fascia transversalis is covering in the entire extent. Okay, and towards medial side is from the conjoint tendon and the reflected part of IL, inguinal ligament. Conjoint tendon, reflected part of this inguinal ligament are forming just the medial part of your posterior wall. Okay. If you take a sagittal section of the inguinal canal, the sagittal section we are seeing from the side. Okay, so what you will see your external oblique aponeurosis that will be surrounding the inguinal ligament like this in the entire this. Okay, and then your transverse abdominis and the internal oblique muscle, which will be forming a conjoint tendon. So conjoint tendon, fascia transversalis. Okay, and these are some these fibers are some arched fibers of your transverse abdominis and the internal your internal oblique muscle. okay, which are forming the roof of the inguinal canal. So forming the roof of the inguinal canal, okay, and the floor is formed by inguinal ligament. This is the inguinal ligament, okay, inguinal ligament, okay, and your lacunar ligament. Lacunar ligament is a modification. Look at this. This is a modification of your inguinal canal. Okay, sorry, inguinal ligament. Okay, lacunar ligament is a modification of your inguinal ligament. Okay, so you will see the lacunar ligament, the floor, forming the floor of your inguinal canal. So let me revise you. Your anterior wall is formed by external oblique aponeurosis, okay, and your internal oblique muscle. The posterior wall is formed by your fascia transversalis, okay, conjoint tendon, and the reflected part of inguinal ligament. Sagittal section, between sagittal section, the roof is formed by the arched fibers of internal oblique and transverse abdominis. Roof is formed by the arched fibers of internal oblique and transverse abdominis, okay, and the floor is formed by inguinal ligament plus your lacunar ligament, inguinal ligament and your lacunar ligament. These are forming a floor. Understood? So you can see the inguinal ring, the SIR. This is the superficial inguinal ring. This is the deep inguinal ring which is formed here. You can take a screenshot and try to correlate it with this diagram. I have no time to explain this diagram. Done? Okay. Let's move on. Let's move on to the content. So in males, the inguinal canal in males contains the spermatic cord and the ilioinguinal nerve. Ilioinguinal nerve is the coming from the first part of your lumbar plexus. Okay, we'll discuss the lumbar plexus. Don't worry. And in females, what are the contents? So you have the round ligament of the uterus and the ilioinguinal nerve. Okay, round ligament of uterus and your ilioinguinal nerve. These are present in your females. Round ligament of uterus and your ilioinguinal nerve also. So ilioinguinal nerve is common, but we have the spermatic cord in males and the round ligament of uterus in females. Okay, and this ilioinguinal nerve is also called the pseudo content of the inguinal canal because it's not present throughout. Okay, it will just enter and leave at the superficial inguinal ring. Okay, like this. This is your lacunar ligament is forming the floor. We can see this in the inguinal ligament and all. Okay, you can see this diagram for more details, and this completes the inguinal ligament, rectus sheath, and the inguinal canal. Okay, each of which can be a short note. Okay, so let's move on to the next concept, and the next concept is called as a spermatic cord. Spermatic cord is present only in males. Okay, so we what we have the spermatic cord. Okay, in the spermatic cord, the layers. Okay, so we have the external spermatic fascia. This is the external spermatic fascia guarding it. External spermatic fascia is the continuation of external oblique aponeurosis. We have the cremasteric fascia, which is a continuation of internal oblique and the transverse abdominis, IONTA continuation. That's the continuation of conjoint tendon, you can say. Okay, and the internal spermatic fascia, in the internal spermatic fascia is the continuation of your fascia transversalis. Okay, and here you have a arrangement. What is this arrangement? You have a testicular artery. Okay, you have the testicular artery here, and this testicular artery, the walls of testicular artery, you have your sympathetic nerves present. Okay, and the pampiniform plexus. Remember the pampiniform plexus we talked about in your pelvis part. Okay, yes. And then we have the remains of processus vaginalis is present. Okay, then the ductus deferens or the vas deferens is present. Okay, so we are generally looking at our transverse section of the spermatic cord. If this is the spermatic cord, taking a transverse section, looking at the things which are present. The ductus deferens or the vas deferens is present over here. Okay, and then with the artery ductus deferens, and the genital branch of genitofemoral nerve is also seen here. Genital branch of genitofemoral nerve. Okay, and between this cremasteric fascia and the internal spermatic fascia, we have your cremasteric vessels. Cremasteric vessels are also present. Cremasteric artery and the cremasteric vein. What are the mechanisms of inguinal canal? What are the mechanisms? Okay, so we can have B square F mechanism, that is a ball valve mechanism, shutter mechanism, slit valve mechanism, and a flap valve mechanism. Ball valve, shutter, slit valve, and a flap valve. Okay, so let's talk about the flap valve mechanism due to oblique nature of inguinal canal. Okay, so discussing the mechanisms of inguinal canal. Due to oblique nature, what happens if there is an intra-abdominal pressure increases on the inguinal canal? Okay, the anterior wall and the posterior wall, they can come close. Okay, and the oblique nature can prevent the contents to move out. This is called flap valve mechanism. Shutter mechanism is due to internal oblique muscle. Okay, it is triple relation with the inguinal canal. Okay, when the internal oblique muscle contracts, the floor and the roof, they approximate and increase the strength of the inguinal canal. Okay, as the internal oblique muscle is present in both in the roof, anterior wall, and the posterior wall, so it is causing the shutter mechanism. Shutter type of action will increase the strength of the inguinal canal. Then the ball valve mechanism, this is by the cremaster muscle contraction, okay, due to which the inguinal canal, the SIR, the superficial inguinal ring, this is clogged due to cremasteric muscle, the cremaster muscle, you know, in the present in the scrotum. Okay, if it contracts, the inguinal canal can be clogged, okay, and it disallows the structure to go out of the inguinal canal. And the slit valve mechanism, okay, so external oblique muscle aponeurosis is responsible, not the muscle, just remember. Okay, so external oblique aponeurosis, this provides integrity to the inguinal ring, okay, by pulling the medial and lateral crura of your SIR. Okay, superficial inguinal ring has the medial and the lateral the crura, okay, and this is pulled by your external oblique aponeurosis, and thus it maintains the integrity of the walls of your superficial inguinal ring. So superficial wall inguinal ring, the integrity is maintained. Okay, so we talked about a slit valve, your ball valve, so Sutter mechanism and a flap valve mechanism, which are preventing the contents of the inguinal canal to come out, as well as they are preventing stability to the inguinal canal. Okay, so you can include these mechanisms in if there is a short note to for the inguinal canal. Okay, so that's all in inguinal canal. Let's move on to the next concept, that is hernias. Okay, so I have an important concept here to discuss, that is your hernias. So we'll discuss the content of each of the hernia, the sac and the covering. Okay, so we have the three parts of the hernia. Okay, like if there is a the hernia will come out of a opening, okay, and the constricted part of the hernia is called the neck of the hernia. Okay, and it is covered by the anterior abdominal wall contents. Okay, and peritoneum will be covering it, and the content will be the your intestine in this case. Okay, your intestine has come out in this case. So you can have variety of hernias. Talking about the inguinal hernia, that is your external hernia. Okay, we have a concept called as the Hasselbalch triangle. So let's discuss the Hasselbalch triangles. So let's read about the Hasselbalch triangle. Hasselbalch triangle, how it is formed. Just see, here is our ASIS and the inguinal ligament that is going up to the pubic tubercle. Okay, and this ligament this is your inguinal ligament. Okay, this is your inguinal ligament, and superficial inguinal ring is present over here. Okay, and your inferior epigastric artery is present here. Inferior epigastric artery is present here, and here you have the rectus abdominis muscle. Rectus abdominis muscle. Okay, so it is bounded. It has two parts. Like this triangle is formed. This is a Hasselbalch triangle. Okay, and it has two parts. Here one, it is a lateral part, and two, which is your medial part. Okay. So what happens? This thing is your Hasselbalch triangle. It is bound by your inguinal ligament, okay, your inferior epigastric artery, and your rectus abdominis muscle. Okay, so this triangle is formed. Then what we have, that we have inguinal hernias, maybe of two types, indirect or direct. Okay, indirect is called as the oblique hernia. Like if you have the inguinal canal here, okay, the hernia will protrude through this canal like this. Okay, so the superficial inguinal ring. Okay, and this is a foramen transversarum over here. Okay, and the indirect hernia, this will break upon your foramen transversarum. Here the foramen transversarum is intact. Okay, and here it breaks upon, the direct hernia breaks upon the foramen transversarum. Okay, and will protrude into this sac like this, protrude like this. Okay, so what are the coverings of the indirect hernia? Coverings are important. Okay, and indirect hernia is common in newborn because of non-oblique nature of inguinal canal. Okay, indirect hernias, due to non-oblique nature, it is very common in newborn. Okay, like the inguinal ring must be like this. Okay, the inguinal canal must be like this, so hernia can easily occur. Due to oblique nature, it becomes a little bit difficult, but it occurs. Okay, it occurs. The skin is there, your external spermatic fascia will be there, cremastric fascia will be there, internal spermatic fascia will be there, extraperitoneal connective tissue will be there. Okay, so this only 5. Okay, these are your coverings of your indirect hernia. So you can observe all three. This all three are the you have read in the spermatic cord, and the skin is covering. Okay, and the extraperitoneal connective tissue is there. Understood? So this is the indirect hernia. This is the indirect inguinal hernia, and this is a direct hernia. Okay, this is your direct hernia. Understood? So you can just observe the things what are there. Okay. And here you have another direct hernia, how it appears in the laparoscopic view. Okay, the laparoscopic view. So in the parietal peritoneum is still covering the area. Okay, the parietal peritoneum is covering the area, and you can see the Hasselbalch triangles also. The inferior epigastric vessels are there. Okay, and a part of Hasselbalch triangle can be observed here. Talking about direct hernia is directly from your Hasselbeck's triangle. Okay, if there is the hernia from lateral part of Hasselbeck's triangle, we call it lateral direct hernia, and from medial part we call it medial direct hernia. Okay, so lateral direct hernia, the covering tissues are skin, external spermatic fascia, cremastic fascia, fascia transversalis. Okay, there is no internal spermatic fascia where fascia transversalis must be present. Okay, FT is present over here. Okay, it will form a covering of the indirect hernia and extraperitoneal connective tissue. Of medial direct hernia, we have a skin, external spermatic fascia, the conjoint tendon. Yes, the conjoint tendon will be present over here, and the fascia transversalis in the place of a cremastic fascia and extraperitoneal connective tissue. Okay, so just you can get an idea of all the structures which are there. The skin is common, external spermatic fascia is common, cremastic fascia is present in the lateral direct hernia but absent in the indirect medial direct hernia, where conjoint tendon is present, and fascia transversalis is common and the extraperitoneal connective tissue is common. So one content is different, you can note it. And after this, your direct hernia and indirect hernia, we come to the end of the hernias. Okay, and let's now move on to the next part. Let's read about the posterior abdominal wall. Okay, so we have the muscles like a quadratus lumborum. Okay, and you have a psoas major, quadratus lumborum, and the psoas minor present over here. So to discuss this three muscles, psoas minor is usually not present. Okay, and the iliopsoas tendon, you know about the iliopsoas tendon. Okay, talking about this, let's discuss the muscles. So quadratus lumborum, you can see the muscle here. So originates from the iliac crest and the transverse process of L5. Okay, it originates from the iliac crest and the transverse process of L5, and it inserts into the 12th rib, the transverse process of the 12th rib. Okay, and it is lateral to the psoas major. So you can see the psoas major muscle here. This is a psoas major present. Okay, and this quadratus lumborum is present laterally to the psoas major. Okay, and then we have the iliacus here, the psoas minor here. Okay, so psoas minor is basically a muscle which is not always present. Okay, and psoas major is always present. It is present in all. So it originates from the transverse process and body of all lumbar vertebrae. Okay, this was originating from the transverse process of L5 only, but psoas major originates from the transverse process of all lumbar vertebrae and inserts into the lesser trochanter. It is inserting into the lesser trochanter of the femur. Okay, so what are there in the posterior abdominal wall? You have the diaphragm, the medial arcuate ligament, the lateral arcuate ligament. You can see in the diaphragm you have a medial arcuate ligament, this one, and the lateral arcuate ligament, the crus of diaphragm and all. Okay, and we have the transverse abdominis muscle present over here. Okay, and this is a part of your anterior wall. Okay, just note that this is a muscle is a part of your anterior wall. It's present more anteriorly. In the posterior part, we have the quadratus lumborum, we have the iliacus, the psoas major, and the psoas minor if it is present. Okay. Talking about the lumbar plexus, we discussed the lumbar plexus in our lower limb also. Okay, and when you are discussing the lower limb in your rapid anatomy marathon sessions, okay, in the upper limb and lower limb video part 1, we discussed about the lumbar plexus. Let's discuss it again. So lumbar plexus, the root values are your L1 to L5. Okay, L1 to L5. From L1, one nerve comes and divides into two, that is your iliohypoglossal nerve and your ilioinguinal nerve. Okay, IHN and your IIN. Iliohypoglossal and your ilioinguinal nerve. Okay, from L1 to L2 there is the genitofemoral nerve, that is from L1 L2 genitofemoral nerve arises. Okay, and from L2 L3 and L4 your femoral nerve arises. Okay, the dorsal division, from the dorsal division of L2 L3 and L4 the femoral nerve arises, and the obturator nerve arises from the L2 L3 and L4 from the ventral division. Okay, so from L1 your iliohypoglossal and ilioinguinal, from L1 and L2 your genitofemoral nerve, from L2 L3 and L4 from the dorsal division we have a femoral nerve, and L2 L3 and L4 from the ventral division we have our obturator nerve. Okay, and the accessory obturator nerve, it arises from L3 and L4 segments. You can see the L3 and L4 segments giving origin to the accessory obturator nerve, which is optional. So we have our, from arising from L4 and L5 segments, we have our lumbosacral trunk. Okay, so genitofemoral nerve, the root values are L1, L2, ilioinguinal L1, iliohypoglossal also L1, and then from L2 and L3 segments from the dorsal division of L2 and L3. Okay, another nerve is arising which is a genitofemoral nerve. Okay, which has a genital branch, has a femoral branch, and the root values are L1 and L2. Okay, and this is not a genital femoral nerve, it is a lateral cutaneous nerve of thigh. The root values is L1, L2 and L3. Okay, I said it originates from your L2 and L3. Okay, so it is called as a lateral cutaneous nerve of thigh, and if it is compressed deep to the inguinal ligament, it can cause a meralgia paresthetica. Okay, and this genitofemoral nerve, this is genital branch and a femoral branch, as I talked earlier. Okay, we'll discuss this diagram now. So in this diagram you can see this is the 12th rib and the quadratus lumborum muscle you can see, and the psoas major muscle is running like this, and your iliacus is running like this. The muscle that is your psoas major, okay, your psoas major muscle is taking origin, okay, it is like attached to the transverse processes of this the transverse process of this 5 lumbar vertebrae. Okay, and this muscle is being pierced by the genitofemoral nerve. You will have your lumbosacral trunk which will be arising, you can correlate from here. The lumbosacral trunk is arising from L4 to L5, and the genitofemoral nerve will be arising from your L1 to L2. So this is the genitofemoral nerve which will be coming like this, and it is piercing the muscle and coming out. The lumbosacral trunk from L4 to L5 will come out like this, and the obturator nerve will pass through the ala, this part and this part. This is the ala of the sacrum, this part and this part. Okay, so it will be passing in front of the ala and the femoral nerve like this, femoral nerve, and it will go down. And the lateral cutaneous nerve of thigh, this is the lateral cutaneous nerve of thigh, which will come in front of your quadratus lumborum and your iliacus muscle, and this IHN and IIN, your iliohypoglossal nerve and your ilioinguinal nerve will come out from this point. Okay, and the subcostal nerve from here below the rib, below the 12th rib. Okay, this is all about this diagram. And let's talk about the thoracolumbar fascia. So thoracolumbar fascia has 3 layers, that is your anterior layer, middle layer and the posterior wall. Okay, your anterior layer, middle layer and the posterior wall, posterior layer you can say. Okay, so you have the psoas major fascia and forming thoracolumbar fascia. And talking about this, we have the transverse section which is showing your thoracolumbar fascia. This is the psoas major muscle which is attached to this part, the pedicel of your vertebrae. Okay, and to the transverse process, the muscle that is quadratus lumborum, it is attached, and to the erector spinae and the multifidus and many other muscles are attached like this. So this green fascia is called as your thoracolumbar fascia. And the kidney fascia surrounding the kidney, that is a renal fascia, and you have the psoas major fascia which is surrounding the psoas major muscle. This internal oblique and the transverse abdominis, this both muscles, these are originating from a thoracolumbar fascia, as we learned in the previous things. Okay, so this is your thoracolumbar fascia. Talking about the next parts of the abdomen, let's move on to the next part. So we are finally into the very important and the part that requires your full attention. So please pay attention to the blood vessels of the abdomen. Here is our aortic opening of the diaphragm at the T12 level, and this is the crus. Okay, the crus of the diaphragm, right crus and the left crus. So this part is called as your abdominal aorta. This is your abdominal aorta. Up to this T12 level, we had the thoracic aorta. From this part we have the abdominal aorta, and giving 2 branches. The abdominal aorta first gives 2 branches in the upper region, which is called the inferior phrenic arteries. This is the inferior phrenic artery and the inferior phrenic artery, and your superior suprarenal artery arises from your phrenic artery. And then we have another branches, that is your middle suprarenal artery, that also arises directly from the abdominal aorta. Then we have the celiac trunk. We'll see about the celiac trunk, which arises the lower border of the T12. This must be the lower border of the T12. So it arises, the celiac trunk arises from the lower border of T12. Then again we have the superior mesenteric artery, which arises the lower border of L1. After T12 we have our L1. So this is our L1, and here the superior mesenteric artery arises the lower border of L1. Then we have the renal arteries, 2 renal arteries. These are the renal arteries, and from this renal artery we have our you have our inferior suprarenal artery. So inferior suprarenal artery is a branch of your renal artery. Your middle suprarenal artery is a branch of your directly it arises from the abdominal aorta, and the superior suprarenal artery arises from the inferior phrenic artery, and these three arteries are gonna supply the adrenal gland. Did you understand this? Let's move ahead. Then you have the gonadal branches. These are the gonadal arteries, and another branch which is arising in the plane of the paper, that is the inferior mesenteric artery, which arises in the body of L3, which arises in the body of L3. And then we have few other branches that are your lumbar arteries. Lumbar arteries given at this point. Then it divides, the abdominal aorta divides into your common iliac artery. Okay, common iliac artery, and this common iliac artery divides into external iliac and the internal iliac arteries. Okay, and another branch is there which is arising from the medial part, the median part, the middle part, which is called as your median sacral artery. So these are the branches of your abdominal aorta. You can mark well the branches. You can see the branches here. Of course, it's not much visible. Let's discuss the celiac trunk. So celiac trunk, if I discuss about the celiac trunk, this is your celiac trunk, and this celiac trunk has like three branches: your left gastric artery, okay, your common hepatic artery, and your splenic artery. It has three branches. Okay, it is the left gastric artery, the common hepatic artery, and another branch which is the biggest branch, the largest branch, okay, which is the splenic artery. So these arteries are going to supply the spleen and your stomach and your gallbladder. So let's see how they are arranged. First of all, let's come here. Okay, this is the celiac trunk. From the celiac trunk arises your splenic artery. Splenic artery goes posterior to the stomach, and posteriorly it gives three branches. There's 1, 2, and 3. Okay, what are this 1, 2, and 3? This 1, 2, and 3 are your dorsal pancreatic artery, your arteria pancreatica magna, and your arteria pancreatis caudae. Okay, dorsal pancreatic artery, arteria pancreatica magna, and arteria pancreatis caudae. This one is your dorsal pancreatic artery. This is your pancreatica arteria magna. Okay, arteria pancreatica magna, or your magnum pancreatic magnum artery, you can say. And the third one is the arteria pancreatis caudae. This is the arteria pancreatis caudae, and it divides into hilar branches, 5 to 7 hilar branches, which are gonna supplying the spleen. And we have the left gastric artery. The left gastric artery is coming to the lesser curvature here. It is coming to the lesser curvature and giving an esophageal branch. And we have the right, the right gastric artery. The right gastric artery doesn't directly arise from this part. So what happens is that from a celiac trunk, we have a common hepatic artery. This common hepatic artery. Okay, and cystic artery is there, which is your right branch, and the left branch is a hepatic artery proper. This is a hepatic artery proper. It is a right branch and a left branch. Okay, and this from this right branch is a that cystic artery which is supplying the gallbladder. So this hepatic artery proper, it is connecting to the common hepatic artery. Okay, and this hepatic artery proper and the common hepatic artery. From this hepatic artery proper also another branch is given, which is called as your right gastric artery. Okay, so right gastric artery is not a independent branch of the celiac trunk. It arises from a hepatic artery proper. And besides this, this hepatic artery proper and the common hepatic artery, this form your, this can form your gastroduodenal artery. This gastroduodenal artery, it goes posterior to the stomach. Okay, and it comes out and forms a anterior branch of superior pancreatico-duodenal artery and a posterior branch of a superior pancreatico-duodenal artery. And it also gives a branch, the gastroduodenal artery gives a branch which is called as a supraduodenal artery in the front part. Understood? Then we have, arising from the gastroduodenal artery, we have our right gastroepiploic artery, which will supply the greater curvature. Then we have the left gastroepiploic artery also, which is supplying the rest part of your greater curvature. So we have the left gastroepiploic artery and your right gastroepiploic artery, which are supplying the greater curvature, and the lesser curvature is supplied by the left gastric artery and the right gastric artery. This completes your arterial supply of the stomach. So we are just gonna discuss the arterial supply of the stomach. When we are discussing the stomach, it will be easy for us. What is the largest branch of your splenic trunk? That is your splenic artery. Okay, it is not a splenic trunk, it is a celiac trunk. Sorry, we have a problem here. This is not a splenic trunk, this is your celiac trunk. This is a splenic artery, and the largest artery of the stomach is the left gastric artery. Largest artery of the stomach is the left gastric artery. Most common variation of cystic artery. So it originates from hepatic artery proper instead of its right branch. Okay. So what happens is that the cystic artery arises from hepatic artery proper directly instead of this right branch of your hepatic artery proper. This is the most common variation of your cystic artery, and right gastric artery is most commonly a branch of hepatic artery proper. So this right gastric artery, this right gastric artery is most commonly is a branch of your hepatic artery proper, but it can arise from elsewhere also. Duodenal ulcerations in the first part can erode the gastroduodenal artery. If there is duodenal ulcerations of the first part of the duodenum, it can erode your gastroduodenal artery. This is a clinical. And retroduodenal branch of gastroduodenal artery is the main arterial supply of the bile duct. There is a retroduodenal branch also of the gastroduodenal artery. It's the main arterial supply for the bile duct. After this, let's move on. So superior mesenteric artery and the inferior mesenteric artery. What are the branches of the superior mesenteric artery and what are the branches of your inferior mesenteric artery? So superior mesenteric artery has 5 branches, okay, which it supplies to the large intestinal part, okay, and inferior mesenteric artery also is supplying the this part. We'll see about that. And the superior mesenteric artery is the main artery that is supplying a large intestine, and a few parts are supplied by the inferior mesenteric artery also. Talking about the branches, superior mesenteric artery has inferior pancreatico-duodenal artery, jejunal and ileal branches, middle colic artery, right colic artery, and ileocolic artery. This middle colic artery is the main artery of your transverse colon. Right colic artery will supply your ascending colon, and ileocolic artery will supply will have a cecal branch and appendicular branch, and will supply the appendicitis, the appendix, not appendicitis. So superior mesenteric artery will supply will have 5 branches, that is inferior pancreatico-duodenal artery, jejunal and ileal branches, middle colic artery, right colic artery, and ileocolic artery. And this inferior mesenteric artery will have 3 branches, that is a left colic artery which supplies the descending colon, sigmoid artery which supplies the sigmoid colon, and superior rectal artery which supplies the upper part of the rectum. And superior artery is the continuation of your internal of your inferior mesenteric artery. This continues as the superior rectal artery in the later part. So talking about the blood supply, so what happens is that you can focus on this part. This is the third part of your duodenum. Okay, this is the third part of the duodenum. This is the third part of the duodenum, and here we have the artery that is your superior mesenteric artery, and also gives a branch that is inferior pancreatico-duodenal artery, which will go back and supply the pancreas and duodenum. Okay, part of duodenum. So it comes back. It arises. The artery arises and is going on like this, and it is giving many branches, that are jejunal and ileal branches supplying the small intestine. Okay, and this is M means your middle colic artery. This middle colic artery is going on and supplying the, which colon is this? This is ascending, this is the transverse, the descending colon. So middle colic artery will come and supply your transverse colon, and this is the right colic artery, and this is the ileocolic artery. This right colic artery comes and divides into 2 other branches, okay, 2 branches like this, and it gives branches to the ascending colon. And this ileocolic artery, this also comes and divides into 2 other branches. This 2 branches of one, and this give branches to your sigmoid and to your appendix. Okay, it gives branches to your appendix, your cecum and all. So these branches are called as your cecal arteries. Okay, these are your cecal arteries, and here you have an appendicular artery. So appendicular artery also is a branch of your inferior, so your ileocolic artery. So these all arteries divide into ascending and descending branch, like your middle colic artery dividing into ascending and descending branch, and this is supplying the whole part of your transverse colon. This right colic artery is supplying the ascending and descending branch and supplying the transverse colon, and this ileocolic artery is also supplying the transverse colon, some parts, and the cecum and your appendix, and your ascending branch and your descending branch is there, and it is joining with the jejunal, the continuation of jejunal and ileal branches. Okay, so this is your superior mesenteric artery. and these small branches are called as the arcuate arteries. Then we have the inferior mesenteric artery. Talking about the inferior mesenteric artery, this is the inferior mesenteric artery present over here. So it has like branches, that is that is the sigmoidal artery. So it is supplying a sigmoid colon. It's a sigmoidal artery, and also anastomosing with L. What is L? L is a left colic artery, which will also divide into two branches, ascending branch and descending branch. This ascending branch is supplying this all parts of your transverse, some parts of your transverse colon as well as your descending colon mainly. So left colic artery is mainly supplying a descending colon and is also anastomosing with the sigmoidal artery. And then the inferior mesenteric artery continues as the superior rectal artery. You can consider the superior rectal artery as a branch also, but it is actually the continuation of your inferior mesenteric artery. Okay, so this completes the blood vessels of the no, we have another things. Okay, I left this things. Yes. So let's talk about the arc of Riolan. What is the arc of Riolan? So what happens is that another important concepts are there, like a marginal artery of Drummond and all, Sudex point and all. So what happens is that here you have the arteries that is supplying. Okay, here you have the artery that is supplying. So we have your ICA, that is your iliocolic artery, okay, and the RCA, that is your right colic artery. The middle colic artery, which is supplying the transverse colon mainly. This right colic artery is supplying the ascending colon. This iliocolic artery was supplying the cecum and the appendix, and this left colic artery was supplying the descending colon. The sigmoid artery was supplying the sigmoid colon. So in 5% of people, what happens is that so let's discuss the arc of Riolan first. So if there is a connection between the middle colic artery and the left colic artery, this is called, this forms an arc, which is called as the arc of Riolan. So this is a clinical. Then what happens in 5% of people, there is an absent anastomosis, means the middle colic artery and the left colic artery, this anastomosis at this point. Okay, this left colic artery anastomosis at this point, but in 5% of people this anastomosis is absent. In 5% people, and this is the fact. Okay, this anastomosis is absent in 5% of people. So in this this one is called as the marginal artery of Drummond. Okay, so if this anastomosis is absent, this is called as the marginal artery of Drummond. Then what is the Griffith's point? This point is called a Griffith's point, which is most vulnerable to ischemia. And we have a Sudex point here in the sigmoid colon. We have the Sudex point, which is also vulnerable to ischemia. This is a retrosigmoidal junction. Retrosigmoidal junction is called the Sudex point, which is vulnerable to ischemia. So right colic artery and the middle colic artery are most commonly absent arteries of the gut. Okay, so in most of the persons, the right colic artery are absent and the middle colic artery is also absent in few people. Okay, so comparatively, not in all, mostly it is present, but this right colic artery is often absent in few people, and the absence of right colic artery is more than the middle colic artery. Okay, this completes the blood vessels of the abdomen. Let's move ahead. Let's come to the another concept, which is called as the portal vein, and let's talk about the portal hypertension or caput medicine and other important things. So portal vein is 8 cm long, formed between the neck of the pancreas at the L2 level by the junction of splenic vein and superior mesenteric vein. This is a junction of the splenic vein and the superior mesenteric vein. So superior mesenteric vein will come from here. This is the superior mesenteric vein, and let's take some other color. Yes, red. Superior mesenteric vein from this part. Okay, and splenic vein from this part, and this both join at the L2 level, neck of the pancreas at the L2 level, and form your portal vein. And this portal vein has three parts, that is the infraduodenal part, your retroduodenal part, and supraduodenal part. So this is the infraduodenal part, which lies back, okay, posterior to the duodenum. It is your retroduodenal part, and the part which is above, it is called as the supraduodenal part. Infra, retro, and supraduodenal parts. Okay, talking about the relations, what are the relations of infraduodenal part? We have the anterior relation, that is the neck of the pancreas. Just see, we are talking about the infraduodenal part. So here we have the neck of the pancreas. Of course, you can see the neck of the pancreas, and posteriorly we have the inferior vena cava. The inferior vena cava must be present like this somewhere. Okay, Posterior part of infraduodenal part is the inferior vena cava. Of the retroduodenal part, you have the anterior relation, that is the first part of duodenum, retroduodenal artery and the bile duct. So anterior relation is the first part of duodenum. And here we'll see in the duodenum that bile duct is present. The bile duct is present over here, and the retroduodenal artery also. And in posterior relation, we have again your inferior vena cava. Inferior vena cava is present posteriorly to all of this. Talking about the supraduodenal part, anterior relation is the bile duct plus your hepatic artery. So your bile duct must be present and the hepatic artery must be present, and posterior relation is again inferior vena cava. Talking about the branches of the portal vein, what are the branches of the portal vein? So let's look at the branches, and let's talk about the branches. So talking about this, we have our superior mesenteric vein and the splenic vein. From the splenic, we have the inferior mesenteric vein here. Okay, inferior mesenteric vein. The superior rectal vein is also present and forming a splenic vein. The splenic vein and this superior mesenteric vein are forming a portal vein. So portal vein is the first branch, which is the right gastric vein and your left gastric vein. The esophageal vein. Just imagine your stomach like this. Okay, so you have the left gastric vein here, right gastric vein here, esophageal branches here. Can you just correlate with the arterial supply? Yes. Then we have the left branch of a portal vein, right branch. This right branch gives your cystic vein, and this left branch gives your para-umbilical veins. And this part, right gastric vein from this region, and superior pancreatico-duodenal vein is also arising from this portal vein. So there is a portocaval anastomosis of the liver, and let's talk a little bit about liver and caput medusae. Then we'll talk about the portocaval anastomosis and what are the points of the portocaval anastomosis that is present in the liver. So talking about that, our liver has this. We have the impression. If you see the posterior inferior view of the liver. Then we have the inferior vena cava present over here. As in the anterior view of the liver, we have the impression of your IVC, okay, present in the liver. So we have the inferior vena cava present, and this is the ductus venosus, which is connecting. Let's talk from here. This is your portal vein. Portal vein is the right branch and the left branch of the portal vein, and this ductus venosus is connecting your inferior vena cava, the left branch of your portal vein. And this ductus venosus, if it is patent after birth, we call it as portocaval anastomosis will be there. Okay, if it is patent, and if it is patent, but it is not usually patent. Okay, it is not usually patent. And then you have the cystic vein supplying the gallbladder, and the para-umbilical veins. This will like supply your umbilicus. Okay, will supply umbilicus, and the veins of the anterior abdominal wall will also supply your umbilicus, like also carry blood away from the umbilicus as the veins. Okay, to the heart. And this umbilicus is the site of a portocaval anastomosis also. So if there is portocaval anastomosis present, okay, if there is portal hypertension, the portal veins are blocked, like the blood vessels, these are narrowed down, okay, due to hypertension. There is hypertension like that. So what will happen, that will suffer from this caput medusae. We talked about caput medusae like this. This is a caput medusae. You can see tortuous veins. The veins tortuosity increases, and they are radiating veins, tortuous radiating veins. So talking about that, about the portocaval anastomosis in the caput medusae, let's move on to the anastomosing points. What are the points at which the anastomosis is occurring? So our superior mesenteric vein, the splenic vein going in this direction, giving a portal vein. This portal vein splits into a right and the left parts. Okay, and this portal vein gives another branch, is the left gastric vein and the right gastric vein. And at the esophageal branch, there is a hemizygous vein. Remember, if you have red thorax, then there is let me tell you, then there is a this is a hemizygous vein. Okay, hemizygous vein, and this hemizygous vein has a esophageal branch which will come to the and anastomose with the esophageal vein and the lower end of the esophagus. At the lower end of the esophagus it will occur. So we have your esophageal branches, lower, and this anastomosing points. Okay, there is a portocaval anastomosis present over here, and if there is portal hypertension, then esophageal varices. esophageal varices will occur. This is the esophageal varices. Then bleeding can occur in this part. There is a problem. And your inferior mesenteric vein is arising from your splenic vein. This is fusing with the superior rectal, which is continuing as the superior rectal vein. Inferior mesenteric vein is continuing as the superior rectal vein. You know this. And this anastomose with the middle rectal vein, the inferior rectal vein, this point, and anastomose at this point. So this is the anal canal at this, in the site of the anal canal at which the anastomose. Okay, and this medial rectal vein, inferior rectal vein are called as a caval system. So this is a caval system which is formed. And if there is a site of, this is a site of anal canal, is a site of your portal anastomosis. And if there is portal hypertension, then you will suffer from hemorrhoids. Hemorrhoids are your piles. Okay, these are your piles. You can see the endoscopic views. Okay, so there are two regions where the portocaval anastomosis is there. That is your esophagus, lower end of your esophagus, and your anal canal. Okay, at this point your portocaval anastomosis is there, and your also your umbilicus, at which there is a portocaval anastomosis. Okay, and this ductus venosus also in your ductus venosus embryologically in adult there are three sites, that is your umbilicus, and that is again your lower end of the esophagus and your anal canal. But in your embryo they have four sites, that is your ductus venosus is also a site of your portocaval anastomosis. So this completes our portocaval anastomosis and portal vein. Let's move on to the next concept. Let's discuss our peritoneum. Now I want your complete your attention on this topic also, peritoneum, because it is a very important topic. You will not understand your greater sac and lesser sac if you don't pay attention to this. So the parietal peritoneum or your visceral peritoneum, so that if there is an organ, so there is a peritoneal sac. The peritoneal sac, the organ as it moves upward, the peritoneal sac will start surrounding the organ. This, which is close to the organ, is called a visceral peritoneum, and this is outside, it's called as a parietal peritoneum. And due to rotation, this may fuse also. This may fuse like this, and this is called as a zygosis, and the organ becomes retroperitoneal. That is covered by peritoneum on only one side. This side is empty. So this is your formation of a retroperitoneal organ, how a retroperitoneal organ forms. Okay, so let's talk about what organs are peritoneal, what organs are partly covered by peritoneum, and which organs are retroperitoneal. So talking about stomach is well peritoneal organ. First part of duodenum is peritoneal, but second part, third part, fourth part, these are your retroperitoneal. So duodenum as a whole is peritoneal, both peritoneal as well as your retroperitoneal. First part is peritoneal and all three parts are retroperitoneal. Jejunum and ileum are peritoneal organs. Cecum can be peritoneal or can be retroperitoneal. It depends person to person. Appendix is peritoneal. Ascending colon is partly peritoneal. Transverse colon is peritoneal. Descending colon is also partly peritoneal. Okay, so ascending is partly, descending your transverse is peritoneal, and descending colon can be partly. Okay, so you can remember like this. And about your sigmoid colon is again partly. Okay, sigmoid colon is again partly. So we have PCP. Okay, you can note a pattern: partly full. Okay, so you can remember the colons like this. Rectum is partly peritoneal, and the anal canal is a retroperitoneal structure. So what are the retroperitoneal organs? Your second, third, fourth part of duodenum. Your cecum, which can be retroperitoneal, and your anal canal. Functions of peritoneum, what are the functions? It causes the movement of the viscera, it gives protection to the viscera, and the greater momentum used for dialysis and healing power. Peritoneum has high healing power. And talking about this, what are the how can you just see the structures which are subperitoneal, which are retroperitoneal, or which are peritoneal? So we can just look like this. We have your transverse colon. Transverse colon is peritoneal. So peritoneum is covering in the whole part. Peritoneum is covering the whole part. And if the retroperitoneal structure is there, no covering is only on the one part. Okay, this part is not covered. And partly peritoneal means it is covered partly like this. It is covered partly, not also in one of the sides. If it is covered like this, it will be called as a retroperitoneal. But it is covered like this. So it is subperitoneal. So urinary bladder is a subperitoneal structure. Talking about the transverse section of your abdominal cavity. So Talking about this is your stomach, this is your stomach, this is your liver, and this part of the stomach, between the liver and the stomach, we have a lesser omentum. This omentum are nothing but a pads of fat, and below this we have a greater omentum. So we are taking a section from here, so we are taking a transverse section from the right free margin, from the right, this is the right, it is the free. Okay, we are taking a transverse section from the right free margin of a lesser omentum and seeing the structures. So if you see the structures, you can find something like this. We'll discuss this pattern, okay, and how it became like this, how the structure is like this, and how the greater omentum and lesser omentum are arranged. So what happens in embryonic time, we have a liver, we have a stomach and spleen in the same line, stomach, liver and spleen in the same vertical line, and this part is your lesser sac, and this part, this green part, unshaded part, was a lesser sac. But a rotation occurs, the spleen goes to this line, okay, spleen goes here, okay, and your liver goes here, spleen goes here and the liver goes here. So the liver is seen here and the stomach will be present at its place, and the spleen goes here. So accordingly this omentum will rotate, okay, this parts will rotate, and this will form a greater sac, which is above this, it is one greater sac above this line, and lesser sac will be just below this line, but a oblique line, okay, this is the oblique line. So it is the lesser sac and your greater sac. In the due course of development it forms. So let's talk about the structures without much delay, less delay. So if you have this structure, talking about this, we have a liver here, it looks like this in a transverse section, and we have the stomach here, this is a stomach, transverse section of stomach, and we have the spleen here, and the kidneys are present like this, So how the that is covering, okay, how the lesser sac and how the greater sac are being formed. So this is the peritoneal lining, this peritoneum goes here, moves here and here and here, and covers the liver, okay, from only this part is left out, it turns here and goes like this, and it goes like this also, okay. And here there is zygosis, in the posterior surface of liver there is zygosis. We talked about zygosis, remember zygosis, what is zygosis? This one, okay, this is the fusing, but this is not forming any retroperitoneal structure, this is only your zygosis that is being formed here, and it comes here and forms a lesser sac, and surrounds the spleen from this end. Okay, so this is a peritoneal lining, this is your whole peritoneal lining. And if you understood the whole peritoneal lining, let's learn some other things, like this part is called as a falciform ligament. This peritoneum linings, these are forming a falciform ligament, and this is a foramen between the lesser sac and the greater, the lesser sac, which is the open end of the lesser sac, forms a foramen which is called as the epiploic foramen. And here if there is zygosis here, so peritoneum will get dissolved in this part, peritoneum will not be there. So this part, the posterior surface of liver, this part is called as a bare area of the liver, okay, in which there will be no peritoneum. There is a ligament formed between the kidney and the spleen, this lining which is surrounding the kidney and the spleen, this part is called as a linorenal or your splenorenal ligament. And your gastrosplenic ligament is also there, your stomach, between the stomach and the spleen, you have the gastrosplenic ligament. So this is your section, and this is the greater sac, and this is your lesser sac. If you understood the structure, let's see it in this real-time section. So this is a real-time section. Of course, the peritoneal lining, this is the peritoneal lining, you can just see the peritoneal lining, how it is going and all. Okay, these are your groups and all, greater sac, lesser sac and all. So this is a bare, of course you cannot appreciate your greater sac and lesser sac, because these are very small areas which we are for representative purpose, we are drawing large areas. The liver covers the major area, and this part is called as the greater sac, this is the bare area of the liver where there is zygosis. This is not covered by peritoneum, you can see there is no peritoneum here, and your kidneys are retroperitoneal organ, we know about this. and this ligament is your between your stomach and the spleen. This is your gastrosplenic ligament, and this gastrosplenic ligament has two contents: the short gastric artery, left gastroepiploic artery. Short gastric artery and left gastroepiploic artery. So these are the contents of a gastrosplenic ligament. And the contents of a it is a lienorenal ligament is also present, and there is no much like content. We have the epiploic foramen present over here. The lesser sac, the free border of the lesser sac is forming your epiploic foramen, so it is present behind the free margin of your lesser omentum. Free margin of your lesser omentum, behind we have your epiploic foramen, which connects the greater sac and the lesser sac. So epiploic foramen is basically, this epiploic foramen is basically connecting the lesser sac with the greater sac, connecting the lesser sac with the greater sac. Okay. Another thing, hernias in the epiploic foramen is a big headache for surgeons because it can't be expanded in size due to inferior vena cava and the pulmonary vein at its back. You can see there is an inferior vena cava and here is a pulmonary vein. Okay, so if there is any hernia, in the epiploic foramen, so it won't like it can't expand. Okay, so the surgeons have to like find all the things, like go deeper and incise the points and all. Okay, so it is a very headache for your surgeons. You can see the things and okay. Talking about the lienorenal ligament, this lienorenal ligament has contents. In this lienorenal ligament has the contents splenic artery and the tail of pancreas. The splenic artery and the tail of pancreas, and the contents of a gastrosplenic ligament were short gastric artery and the gastroepiploic artery, and the content of a lienorenal ligament are splenic artery and the tail of the pancreas. There is a ligamentum teres. And this ligamentum teres, what is ligamentum teres? This ligamentum teres is called as a obliterated umbilical vein forms ligamentum teres, and it is below the falciform ligament. We'll see about the ligamentum teres in a while when we discuss the liver. Okay, talking about the lesser omentum has a free margin and an attached margin. Lesser omentum has a free margin and an attached margin. So free margin, your portal tride is present, portal vein, hepatic artery and the bile duct. This is a portal tride, and the attached margin of right gastric vessels and the left gastric vessels are present. You can see your lesser omentum probably here. You can see your lesser omentum. This is a free margin and a attached margin. This is the attached margin. This is the attached margin of your lesser omentum. This is attached to the stomach, and this is the free margin. If you can well appreciate, you can easily like appreciate the structures. So free margin is basically this. The stomach was there like this, and this is the attached margin and this is the free margin of it. So free margin is basically containing a portal tride having the portal vein, hepatic artery and the bile duct forming the portal tride, and this attached margin has your right gastric vessels and the left gastric vessels, right gastric vessels and the left gastric vessels. Understood? So this is about your lesser omentum. Talking about the epiploic foramen is also called as the foramen of Winslow. So what is the foramen of Winslow? Talking about this is a lesser omentum. You can see the lesser omentum, which and the free margin of the lesser omentum containing a hepatic artery, bile duct and portal tride. This is portal vein. This is called as a portal tride, and here you can see the epiploic foramen, and the inferior vena cava will lie posterior to it. Right suprarenal gland will also lie posterior to it, and the T12 vertebrae. So what are the anterior relations of your epiploic foramen? Your epiploic foramen, the anterior relations will be this is the anterior part, this must be the anterior part, and this is the posterior part. So anteriorly it is one of the hepatic artery, bile duct and a portal vein. Posterior relations are the inferior vena cava, body of T12 vertebrae and the right suprarenal gland. What is the roof? Roof is the caudate lobe of the liver. Okay, roof is the caudate lobe of the liver. If you can appreciate here, epiploic foramen is present. Yes. So what is the roof? Roof is the caudate lobe. This liver must be present in this plane. Okay, so the caudate lobe of the liver, that is the fourth lobe, will form your roof, and the floor is the first part of duodenum. So you can just remember the roof and floor. Let's now discuss the sagittal section. So we have taken a sagittal section from the side. Okay, and we are seeing the urinary bladder is at the front, the rectum is at the back. Okay, we have the liver and the stomach is there, the transverse colon is there, and we have a small intestine, the pipes, small intestine that are cut. Okay, so it will appear something like this. Yes, so let's discuss your greater sac and your lesser sac in this section, and we'll also talk about the rectouterine pouch or your rectovesicular pouch. Let's talk about this. So this is the liver. This is the liver. Peritoneum is covering it like this, this and this. Okay, and in this part it is covering like this. So this is the lesser sac. This is the lesser sac. This part is your lesser sac, and this whole part, the other part that is starting from this, it covers your stomach and from this transverse mesocolon and extends up to your rectovesicular pouch. This is your greater sac. This is your greater sac. So talking about what lesser sac, so liver, it is covered by a greater sac as well as the lesser sac, and stomach also greater sac and lesser sac, transverse colon also greater sac and lesser sac, and the mesentery, these are covered only by greater sac. So what is the ligaments? Okay, this part is a lesser omentum, this part is a lesser omentum, this is your lesser omentum, and this is your greater omentum, this is your greater omentum. So greater omentum contains your lesser sac. Understood? And this part, the surrounding transverse mesocolon, this part is called as your transverse mesocolon. This transverse colon, the part of peritoneum that is surrounding the transverse colon, is called as a transverse mesocolon. This is called as a mesentery. This is called as a mesentery. This is called as a mesentery. Understood? And this pouch, there is a pouch formed. It is called as a rectovesicular pouch or the pouch of Douglas. And this it is in males. Okay, in males it is called as a rectovesicular pouch, and in females we have the rectouterine pouch or the rectovaginal pouch. Rectouterine pouch. Okay, rectovesicular pouch in males and rectouterine pouch or rectovaginal pouch in the females. In this females, the pouch is formed like this. Understood? And these pouches are the, you can observe that it is lying at the most basal region. So the pouch is most dependent site in the erect posture. Okay, if there is some infection here and it can travel in the pus accumulation. The pus accumulation will be only in your rectovesicular pouch. If there is fluid accumulation, the fluid will drip down to this pouch. So this pouch is the most dependent site in your erect posture. Talking about this, what I was talking about. So this is, there is a subphrenic recess. There is a subphrenic recess formed due to this peritoneal fold. We have the liver present over here, and this pouch, this one. If I take some other color and highlight to you, this one is called as your lesser sac. Okay, or your omental bursa. Don't call it omental bursa, you may get confused. That the pancreas present over here and the stomach is present. So the greater sac is this part starting from here. It will extend there posteriorly. It will extend, and this whole part will be a greater sac. And your lesser omentum, this is your lesser omentum. And talking about the greater omentum, this is your greater omentum. This is your greater omentum. This is your greater omentum. Okay, this is your transverse mesocolon. Sorry, the greater omentum I left somewhere. Let's see. Okay, it is not shown here. No problem. This is a transverse mesocolon. You can see your transverse colon, and the peritoneal folds surrounding it is the transverse mesocolon, and these are your small intestine, the pipes of the small intestine, and these are surrounded by mesentery. This is a mesentery. This is a mesentery, and this is your rectovesicular pouch. You can see this. What are the relations of the lesser sac? So what are the anterior relations, what are the posterior relations, and the left relations and the right relations? And we'll discuss about the greater sac in less detail, not much as this, and we'll talk about the roots of the mesentery and duodenal recesses. So let's talk about all these things. And the anterior relations of the lesser sac. So anteriorly we have the caudate lobe of liver, the lesser omentum, the posterior wall of stomach, the first and the second layer of your greater omentum. Understood? So let's move back to the diagram. So this is your greater, we are talking about the lesser sac, right? This is your lesser sac, this is your lesser sac. So what are the anterior relations? So you can see, first is the caudate lobe of the liver. Caudate lobe of the liver, you can, this lobe is the caudate lobe of the liver. The lesser omentum is the anterior relation of the lesser sac. Lesser omentum is the anterior relation of the lesser sac. The posterior surface of the stomach, the posterior wall of the stomach, and the first and second layer of the greater omentum. Sorry, the diagram is moving. Okay, so as the first and second layer of the greater omentum, which are also forming your relation of your lesser sac, anterior relation of your lesser sac. Talking about what are the posterior relations. So okay, so the structures of the stomach bed, are your posterior relations. So what are the structures of your stomach bed? So you have the pancreas, you have the splenic artery, the left kidney, the left suprarenal gland, the left crus of diaphragm, the aorta, splenic flexure of colon, and the transverse mesocolon, and spleen also, but spleen is not present posteriorly. Okay, then a transverse colon, the third and fourth layer of your greater omentum. These are forming a posterior layer. Okay, and structures of stomach bed will learn the stomach part. We haven't discussed the stomach yet. We will understand more there. And the left is bounded by lienorenal gastrosplenic ligament. It is bounded in the left, and right by it is open via epiploic foramen. So you can appreciate not in this sagittal section, in this section you can see a lesser sac. It is bound to the left and to the right. Okay, and how it is opening? It is opening to the right in the epiploic foramen, and it is bound to the gastroepiploic and your lienorenal and your splenorenal ligament, the lienorenal, the splenorenal ligament. Okay, and your gastrosplenic ligament. So talking about this, you understood all the structures. Left is bounded by your lienorenal and gastrosplenic ligament, and right is open by your epiploic foramen. So you understood all of this. And posterior relations, just have to see the structures of stomach bed. We'll see the structures of stomach bed once you discuss your stomach. Let's discuss the greater sac. Greater sac is via greater omentum is divided into supracholic compartment and the infracholic compartment. So greater sac has a supracholic and an infracholic part, which is not shown here probably. Okay, this is not shown here. Supracholic and the infracholic part. Okay, most dependent site of peritoneal cavity is your hepatorenal pouch. Most dependent site in supine position, not in prone position, in supine position. It is your hepatorenal pouch. It is called as the pouch of Mauritian. Okay, pouch of Mauritian. So you can see the liver and your right kidney. If you can see somewhere, if it is visible, let me find. Okay, this is your liver, and this is the right kidney. So there is a pouch formed between this. There is a pouch formed between this. Okay, which is called as your pouch of Mauritian, which is so you have liver, lobe of liver, and the right kidney, which is pouch is formed, which is called as the hepatorenal pouch or pouch of Mauritian, which is the most dependent site of peritoneal cavity in supine position. Let's talk about the roots of the peritoneum. You can see the roots of the peritoneum. What is the root? Okay, what is the root? It is the junction point, like at what point the peritoneum is going into that structure. Like if you remove if you just keep the structure, if you just remove the structure, okay, remove a part of the structure, and like you cut a part, but you keep the peritoneum intact. Okay, so what will be the roots present? Okay, how the incisions will be seen here. So talking about this, we have this root of transverse mesocolon. This transverse mesocolon is going on like this. If you remove the transverse mesocolon from the peritoneum, the root will be present, root will be intact like this. So it is the root of your transverse mesocolon. And if there is a root of mesentery also, there is a root of mesentery. This is the root of mesentery. So you removed your whole small intestine out from this abdominal cavity, and the fold that will be formed, that is called as the root of the mesentery. And we have the root of the sigmoid mesocolon, which is inverted V shaped. If we remove the sigmoid colon, there will be the presence of the root of the sigmoid mesocolon. Okay, so talking about the root of the mesentery. Root of the mesentery is like going on from the duodenal junction, the duodenojejunal junction to the right sacroiliac joint, or ileocecal junction. You can write ileocecal junction. And what are the contents? Root of mesentery contains your superior mesenteric artery, superior mesenteric vein, some lymphatics, and your nerve plexuses. Okay, and talking about this is your that duodenum part, and you have a muscle that is a psoas major that will be present lying over this region. So it crosses the third part of duodenum. This is the third part of duodenum over it crosses. This is the third part of duodenum. It crosses the aorta and your inferior vena cava. This is your abdominal aorta and your inferior vena cava and your right psoas major muscle. This is your right psoas major muscle. It crosses this also. It crosses the right ureter also. This must be your right ureter. This is your right ureter. If I haven't labeled, let me label this. This is your right. This is your right ureter and your right gonadal vessels also. This is right gonadal vessels also. Okay, ureter is some other part. This is a gonadal vessel, right? Because it is present over in front of the psoas major muscle. So it is your gonadal vessels. Gonadal nerve, you can say. Then let's discuss the root of the transverse mesocolon. So this is the root of the transverse mesocolon. This is the second part of the duodenum, and this is the root of the transverse mesocolon. This is the pancreas, and this is the left kidney. So the content is the middle colic artery and vein. Okay, the content of the root of transverse mesocolon is the middle colic artery and vein, and it crosses the structures like a second part of duodenum, pancreas, and your left kidney. Then let's talk about the root of sigmoid mesocolon. So sigmoid mesocolon, this is a right limb of the sigmoid mesocolon, and this is the left limb of the root of the sigmoid mesocolon, and we have intersigmoidal recess. The left ureter is passing posterior to it, and we have the left external iliac artery in this region. What are the contents? From the right limb we have the superior rectal vessels, and the contents of the left limb are your sigmoidal vessels. Understood? Talking about the duodenal recesses, these are empty pockets of peritoneum which are present in the duodenum. This is a structure which is in 3D, but you can't visualize this in 3D. So it is very difficult to visualize it in 3D. So let's just discuss in the schematic diagram, and I can show you these things also in the 3D part. So first of all, you have a duodenojejunal recess. Here duodenojejunal recess present in 20% of population, and it is about 3 to 3.5 cm deep. Then a superior duodenal recess, which is about 50% of population, 2 cm deep. And the paraduodenal recesses, which are your inferior mesenteric vein is present in its free margin like this. Inferior mesenteric vein in the free margin like this. Your inferior duodenal recess present in 75% of population, and it is a gravity dependent recess, so that there is maximum chances of herniation also. Hernia can be formed. It's a gravity dependent recess. You can just think of a bowl, and if you're putting water, then the water is going down via the gravity. Okay, so inferior duodenal recess is 75% of population. It is about 3 cm deep. And the retroduodenal recess, the duodenal recess is like passing posteriorly, and this is present in 5% of population. It is a deeper recess, 8 to 10 cm deep. And mesenterico-parietal recess just present below the third part. Okay, it is present in less than 1% of population, and superior mesenteric artery and vein are passing via this recess. So we have this duodenal recesses. We have about 6 duodenal recesses. Your duodenojejunal recess, your mesenterico-parietal recess, then your superior duodenal, paraduodenal, retroduodenal, and your inferior duodenal recesses. Okay, so this completes our peritoneum. Let's move on to the next part. Let's discuss the rectum. So what are the features of the large intestine? So large intestine has tinea coli, saculations, and appendix epiploidy. Okay, appendix epiploid. So these are not present in the rectum and the anal canal, but present in the large intestine. Okay, it is present in the large intestine. What is present in the rectum we will see now. But this rectum, this is present in front of the lower 3 sacral vertebrae, and it is 12 cm long. The diameter upper part is 4 cm. The most dilated part of the rectum is called as the ampulla. Okay. Talking about this, we talked about the large intestine. So large intestine has this type of tinea coli present. This type of tinea coli which are present. These are longitudinal bands of muscles, and the appendix epiploic Okay, appendix epiploicae. So these are the appendix epiploicae. There's circulations like this, and these circulations are the hostrations. Okay, hostra that is present. The hostras are present, and this hostral movements in helping the absorption. So this is a cross-sectional view. You can see the view also done. Okay. So talking about rectum, the direction of rectum, the upper one third is downward and backward. It is downward and backward. The upper one third is downward and backward, downward and backward. The middle one third is vertically downward. The middle one third is vertically downward. The upper one third is downward and backward, and the lower one third is downward and forward, downward and forward. Okay, like it is coming forward, like it is coming forward. Understood? So these are the directions of your rectum, and upper one third is downward and backward, middle one third is vertically downward, and lower one third is downward and forward. Okay. This is a sagittal section. You can see the sagittal section and appreciate it. S3, S4 and S5 vertebrae, and there is a raphe which is called as a anococcygeal raphe, which is connecting this S5, this sacral vertebrae, to the rectum. Okay, and we have this pouch that you can identify easily the pouch. This is a rectovesicular pouch, which is also called as a rectouterine pouch or a pouch of Douglas. Okay, so this is the pouch of Douglas, and your urinary bladder, your posterior gland, your seminal vesicle. Understood? So you can just appreciate the structures and how the rectum is present. You can now know. Let's talk about the curvatures of the rectum. So we have anterior posterior curvature. This is the anterior posterior curvature of the rectum, and this is the lateral curvature of the rectum. So anterior posterior curvature, this is anterior posterior curvature, and this is the lateral curvature. So we have the in anterior posterior curvature, we have the sacral curvature and the perineal curvature. Okay, the sacral curvature, it is due to the concavity of the sacrum and the coccyx. Okay, the sacrum of the coccyx is like concave in nature, and sacrum and the coccyx, so it is forming a sacral curvature. And the perineal curvature is due to pulling. Perineal curvature is due to the pulley action of your puborectalis muscle, which is a modification of your pubococcygeus muscle. This perineal curvature is due to your puborectalis muscle. Talking about the lateral curvature, we have the upper lateral curvature and the lower lateral curvature, and the middle lateral curvature. Okay. So upper lateral curvature at S3 and S4 vertebrae level. The lower lateral curvature is at the tip of the coccyx, and the middle lateral curvature is at the sacrococcygeal joint. Let's talk about the peritoneal relations. What are the peritoneal relations of the rectum? So first of all, this is a rectum. This whole part is a rectum. You can see the curvatures well defined. Okay, so this is the upper one third is covered by the peritoneum on anterior side, and on both the sides, anterior and the sides, is covered by the peritoneum. The middle one third is covered only on the anterior side by the peritoneum, and the lower one third is no peritoneum is present. This peritoneum is lying in this rectovesicular pouch. This is the peritoneal pouch, and this is covering the anterior and the sides of the peritoneum, and the middle one third is covering only anteriorly, and lower one third there is no peritoneum. What are the anterior relations of the rectum in males and in females? What are the anterior relations of the rectum? Talking about the anterior relations, we have in the upper part, we have the rectovesicular pouch, the coils of jejunum and ileum, and the sigmoid colon. These are present in the upper part. And in lower part, we have the base of the bladder, the terminal ureter, seminal vesicle, ampulla, vas deferens, prostate gland, and the rectovesicular fascia of the Denon villus. Okay, these are your relations of anterior relations of the rectum. Okay, and then we'll talk about the posterior relations. Talking about the posterior relations, I'm just seeing how much you have to discuss. Okay, so anterior relations, you know, in males, you have a rectovesicular pouch, your coils of jejunum, ileum, and the sigmoid colon. Lower part, base of the bladder, terminal ureter, seminal vesicle, ampulla, vas deferens, prostate gland, and rectovesicular fascia of Denon villus. In females, we have your rectovesicular, in the part of your rectovesicular pouch, you have the rectouterine pouch, coils of jejunum, ileum, and the sigmoid colon. The base of the bladder, your terminal ureters, Okay, in case of seminal vesicles, we have the lower part of vagina and the rectovaginal fascia, not the rectovesicular fascia. We have the rectovaginal fascia. It's very easy if you just think about this. It is very easy. You can just remember like this. And what are the muscles that are like present here? Okay, so this is mainly the space where the rectum will be present. This is the space where the rectum will be present, and if it is a sacrum, it is a L of the sacrum and the sacral vertebrae. Okay, and the coccygeus muscle must be present over here. The coccygeus muscle will be attached, inserted to here, and the levator ani will be inserted to here. This is the origin of the piriformis and the iliacus. Okay, piriformis and your iliacus muscle are present here, and your sympathetic chain must be going on like this, sympathetic chain like this. The medial sacral artery, we talked about the median sacral artery. It is a branch of your abdominal aorta, direct branch of the abdominal aorta, and we have a ganglion to which this both sympathetic chains are converging. This is called as your ganglion impar. So what are the posterior relations for both of the genders? We have this lower three sacral vertebrae. So you can see the lower three sacral vertebrae being S2, S3 and S4, and your coccyx, your piriformis and the coccygeus muscle, piriformis as well as your coccygeus muscle, your levator ani muscle. Okay, you will levator ani, sympathetic chain, your ganglion impar, your medial sacral vessels, the superior rectal artery, and the fascia vulvae. Fascia vulvae is also present. Understood? Talking about the interior of the rectum, this is from the mucosal folds. We have the temporal mucosal folds and the permanent mucosal folds. Okay, the temporal mucosal folds and the permanent mucosal folds. So this temporal mucosal folds, they are temporary, like which vanish in the distended rectum. The rectum is distended. These longitudinal folds vanish. Okay, you can see the mucosal folds are like this. Okay, and talking permanent mucosal folds, these are also called as the Houston's valves. So let's see what are the folds on the Houston's valves. So you have the first transverse fold, your second transverse fold, the third transverse fold, and the fourth transverse fold. Talking about the first transverse fold, it is present at the rectosigmoidal junction. It can be on the right side or your left side. It may be present like this or it may be present like this. It doesn't matter. So first transverse fold, it is at the rectosigmoidal junction, right? The sigmoid and the rectum. The second transverse fold, it is opposite to the upper lateral curvature. It's opposite this upper lateral curvature. It is opposite to the upper lateral curvature. Understood? And the third transverse fold, there is a third transverse fold present over here, and it is opposite to the middle lateral curvature. Okay, this is the middle lateral curvature. So it is opposite to the middle lateral curvature. It's the largest fold. The third transverse fold is the largest fold, is the most prominent fold and the most constant fold. Like it is present in everyone, it's present prominently in everyone. And the fourth transverse fold, it is opposite to the lower lateral curvature. This is the lower lateral curvature. So a fourth fold is opposite to the lower lateral curvature. These distances are constant, like between second and third, 2.5 cm, and 2.5 cm between the third and the fourth. So these folds are present like this, like a third fold is present like this, the second fold, and the fourth fold is present like this. If you see a transverse section. Talking about the arterial supply, we have the superior rectal artery, which will be supplying the rectum, which is a branch of an inferior mesenteric artery. We talked about that. The inferior mesenteric artery, it continues at the superior rectal artery. Understood? The middle rectal artery, which is from the anterior division of your internal iliac artery. So we have a middle rectal artery which is supplying, and the inferior rectal artery also, which is the branch of your anterior division of IIA, that is your internal iliac artery, and IIA is giving, the anterior division is giving pudendal artery, the internal pudendal artery, and the branch of internal pudendal artery is called as your inferior rectal artery. And the median sacral artery, this is a direct branch of your aorta, abdominal aorta. How these arteries are supplying, you can see. So this is your rectum. This, you can draw your rectum like this, and if I draw the rectum like this, we have an internal iliac artery like this, and giving up your middle rectal arteries. These are giving up your middle rectal arteries, and your superior rectal artery, that is the continuation of your inferior mesenteric artery. This is coming, and at S3 level, it is dividing into 4 branches. Understood? And superior rectal artery is the chief artery of the rectum. So what is the chief artery of the rectum? It is a superior rectal artery, which is the chief artery of the rectum, supplies the muscles of the upper part and the entire mucous membrane. And this is a pelvic diaphragm, you can see, and your internal pudendal artery, which is giving up a branch, which is called as the inferior rectal artery, are supplying the terminal regions, the neck region, this terminal region. Understood? And this is the pudendal canal, under which the internal pudendal artery is transversing. After this, let's talk about the venous drainage. So we have the superior rectal vein, which is a part of your portal system. It has 6 tributaries of superior rectal vein are present. And the superior rectal vein, this is from an internal iliac vein. We have a middle rectal vein also, and your inferior rectal vein, and from an internal pudendal vessels, your inferior rectal vein. So that is the anastomosis within the superior rectal veins connecting to the internal the middle rectal vein, and this middle rectal vein and the internal rectal vein are also connected. Understood? So these are forming a venous plexus here. The superior rectal vein, the middle rectal vein form the internal venous plexus, and the inferior rectal vein, okay, and with all these three are forming the external venous plexus. So we have internal venous plexus and an external venous plexus also formed in the rectum. Then for the lymphatic drainage, the upper half is drained to inferior mesenteric lymph nodes, and lower half into your internal iliac lymph nodes. Inferior mesenteric lymph nodes from the upper part, internal iliac lymph nodes for the lower part. What are the supports to the rectum? Supports from the pelvic diaphragm, that is a puborectalis muscle that is providing the support and is responsible for this curvature of the rectum. The fascia vulvae. What is the fascia vulvae? This is a fascia vulvae. You have a sacral vertebrae here, and your rectum is present here. So there is a fascia covering here, and this is called the fascia vulvae. This contains your fat, lymph nodes, and superior rectal artery and the superior rectal vein. Just remember the contents. Then you have the lateral ligament of rectum, which is providing support to the rectum. So lateral ligament of rectum, which is formed due to condensation of the pelvic fascia, and this also contains your middle rectal artery and the middle rectal vein. Then of the rectovesicular fascia of the denonvillus, fat in the ischiorectal fossa is providing support to the rectum, and perineal body, which comprises of a 10 muscle, which we discussed in already in the pelvis. Talking about rectal prolapse, there is an incomplete prolapse of rectum, that is a that is called the mucosal prolapse, where the rectal mucosa protrudes through the anus. Due to excessive straining during defecation, rectal prolapse may occur. And complete prolapse, or it is called as a procedentia. Okay, complete prolapse or procedentia, the rectal wall will protrude through the anum. The whole wall of the rectum will protrude through the anum, and this can cause damage to the primary support. This can cause damage to all these primary supports. Understood? And this complete prolapse is more severe than your incomplete prolapse, obviously. Understood? So this completes the rectum. Let's move on to the next parts of this chapter. Talk about the anal canal now. After rectum, we have our anal canal present in the anal triangle between the ischiorectal fossa, where fat is present. So it allows expansion, and defecation can occur due to this. It's about 4 cm long and present in front of the tip of the coccyx. Okay. So this anal canal is there, the folded and pigmented part. Okay, the skin is folded and pigmented, also called as the corrugator cutis ani. That is the folded skin of our anal canal, corrugator cutis ani. Talking about the anorectal junction, what is the junction between the rectum and the anal canal? So this puborectalis muscle we saw, this is a muscle of continence, we discussed this also. So there is a 90 degree of perineal flexure. If there is less than 90 degree, this angle, if there is less than 90 degree, defecation will occur. Okay. And after this, we have our ischiorectal fossa. Just see what are the relations of the anal canal, inferior and the anterior relations and all. We'll talk about this also. Relations are not separately given probably, so we'll discuss the relations here only. So anal canal, we have our anal canal here. So what are the anterior relations that are present anteriorly, more anteriorly? So we have the bulb of penis and the vaginal wall, and the perineal body, which is a culmination of 10 muscles. Then we have the bulbus spongiosus, the bulb of penis and the vaginal wall, or the vaginal wall. So these are forming the anterior relations, and posterior relations is formed by there's a raphe called as the anorectal raphe. This is the anorectal raphe, and the tip of the coccyx, and the anorectal raphe. These both things are forming your there's a recess. This recess is called the horseshoe recess. We discussed this horseshoe recess, remember? Yes, horseshoe shaped recess that was being formed here in the pelvis. So this is the horseshoe recess, and the anorectal raphe, this is the anorectal raphe, and this is the tip of the coccyx which is forming the posterior wall. Okay, posterior relations. So anterior relations and posterior relations are clear now. And interior of anal canal, we have the upper part that is 15 mm long, and the lower part, upper part is the endodermal part, and lower part is the ectodermal part. So it has 15 mm long pecten and 8 mm long cutaneous part. So this lower part is about 23 mm. Talking about this the interior of anal canal is very important. So you can see how the structure is present, base type of structure. Then we have the anal columns here. These are your anal columns. Which are the long mucosal folds. These are called as the columns of Morgagni. Columns of Morgagni are nothing but your anal columns. And we have the inside the anal columns we have our anal sinuses, which are in which the submucosal anal glands and the ducts open here. And then we have the next part. Okay, this is the lower part, which is ectodermal, which is 15 mm long pecten. This is a 15 mm long pecten, which is covered by a stratified squamous epithelium, stratified non-keratinized squamous epithelium. And then we have the white line of Hilton. There is a white line of Hilton is there. So special names you must have observing, you must remember the names. And the stratified squamous epithelium, which is keratinized. This part is a keratinized part. This is the lower part, lowermost part, and this is the anal orifice, okay, which is cutaneous. Talking about sphincters, we have internal anal sphincter and the external anal sphincter. External anal sphincter, the deep part, so it has a superficial part, it has a subcutaneous part. Talking about this, let's see how the anal sphincters are arranged. So we have the pubic bone here, and the puborectalis muscle. Puborectalis muscle was covering the opening of the anal canal. We know this puborectalis muscle is a modification. This is a modification of your pubococcygeus. Yes, pubococcygeus. Understood? And what are the things we are observing here? So we have the deep part of the external anal sphincter. This is the deep part of the external anal sphincter, just below the pubococcygeus, the puborectalis muscle. Then from the pubic body, we have this type of arrangement, which is called the superficial part of your external anal sphincter. And this superficial part is attached to the sacrum vertebrae. It's attached to the tip of the coccyx by a raphe, which is called the anococcygeal raphe. So we can see here also. Yes, this is the tip of the coccyx. Okay, this is the tip of the coccyx, and it is attached by the anorectal raphe. So anorectal raphe basically connects the superficial part of external anal sphincter, and this is the subcutaneous part of external anal sphincter. Talking about the anorectal ring, let's talk about the anorectal ring and how it is formed. So anorectal ring is formed by your puborectalis, your internal anal sphincter, and the deep part of your external anal sphincter. Talking about how it is formed. So this parts, this one, and this one are forming an anorectal ring. This three parts, when they are combined, they are forming an anorectal ring. And if we just see the diagram here, we have our anal canal like this. This is the white line of Hilton, and you can see there is the long muscles of rectum are coming like this. Your puborectalis is coming like this. Puborectalis from this part, the long muscles of your rectum, they are converging to form a conjoint longitudinal coat. And here in the lining we have our internal anal sphincter, IAS, which is like this part. And then we have deep part of external anal sphincter, superficial part of external anal sphincter, and the subcutaneous part, and this is also your subcutaneous part. So it is just a transverse section. We discussed like this here, and we are taking this transverse section in this level. And we have our perianal fascia also. Just like covering over the subcutaneous part. Understood? Then we have the surgical spaces related to anal canal, which is ischiorectal fossa, your perianal space, and the submucosal space of anal canal. This submucosal space, we know about this ischiorectal and perianal fascias from a pelvic discussion. So submucosal space of anal canal is just present above the white line. So this part just which is present this part, the superficial part. and it is present between the mucous membrane and the internal anal sphincter. Okay, we have an internal anal sphincter here and the mucous membrane, so it is present just between them, and it is a site for internal venous plexus. It has internal venous plexus in the submucosal part of anal canal. Arterial supply: above the dentate line, you have superior rectal artery. Below the dentate line, you have inferior rectal artery. Talking about the dentate line, if I haven't told, so here it's called a dentate line. This part you can see. This line is called as a dentate line. This line is called as a dentate line. Okay, this line is called the dentate line, a curved line. So the pectinate or your dentate line, you can call it pectinate line or your dentate line. So just above the dentate line, it is supplied by the superior rectal artery, and below the dentate line, it is supplied by the inferior rectal artery. Venous drainage: above the dentate line, superior rectal vein; below the dentate line, inferior rectal vein. Very easy. Lymphatic drainage: above dentate line, internal iliac lymph nodes, and below the dentate line, you have superficial inguinal lymph nodes. Okay, horizontal group of superficial inguinal lymph nodes. First, you have to remember the lymphatic drainage. This arterial and venous supply is just very easy. Talking about nerve supply: above the pectineal line, above the pectinate line, you have sympathetic supply from L1, L2, and parasympathetic from S2 to S4. So the pelvic splanchnic nerves, and below the pectinate line, the somatic nerve is the inferior rectal nerve. Okay, somatic nerve, and for sphincters, we have internal and sphincter, which is involuntary. So it's, sympathetic supply is it will contract. Okay, and parasympathetically it will relax. And external anal sphincter, this is voluntary, so it is supplied by the inferior rectal veins plus your S4. Inferior rectal veins plus your S4. Talking about what are hemorrhoids. Hemorrhoids are piles. It is important. This is a variceal dilation of submucosal venous plexus. Okay, so in anal canal we have the submucosal venous plexus. So we told that this mucus layer, the submucosal space of anal canal, which it is a site for your internal venous plexus. So if there is a dilation, dilation of the submucosal venous plexus, there will be hemorrhoids or piles. Due to portal hypertension, it may be caused. This internal hemorrhoids are the primary piles or the true piles. It is caused due to portal hypertension, but the superior rectal veins tributaries get dilated above the pectinate line, because superior rectal vein is supplying above the pectinate line. Talking about what are the positions where internal piles can occur. So this is the anal canal in the transverse section. So we have the 3 o'clock position. You can just imagine this like a clock. So it will be 3 present over here, 11 and 7. So we have 3, 7 and 11. 3 o'clock, which is your left lateral primary pile, and your 7 o'clock position, which is right posterior primary pile, and your 11 o'clock is the right anterior primary pile. So lots of bleeding occurs, but your primary piles are mainly painless. Bleeding will occur, but they are painless. And external piles is the dilation of tributaries of inferior rectal vein, and they don't bleed profusely, but they are very painful. Okay, so these are some diagrams you can see of your anal canal. Done. Okay, so that completes our anal canal. Let's move on to the next part. Let's talk about an important organ, which is the spleen. So spleen is one of the important organs. The junction, the function, not the junction. This is, yes, function is to remove out the worn RBC, worn out RBCs. So spleen is called as a graveyard of RBCs. Okay, it is called as a graveyard of RBCs. We know this fact. And the fetal life, it also manufactures RBC, and it also does the storage. Okay, so it is forming RBC, removing RBC, and storing RBC. So it is mainly intrinsically connected to your RBCs and all. Okay, hematopoiesis and all. So what is the location? Location is the left hypochondrium. We know the region left hypochondrium. That's why I discussed the quadrants of abdomen in the very beginning. This is present in the left hypochondrium. What is Harris dictum? Harris dictum helps. It is a really mnemonic, okay, which helps to remove remember the dimensions of the spleen. So we have 1, 3, 5, 7, 9 to 11. 1, 3, 5, 7, 9 to 11. These are odd numbers. So 1, what is 1? 1 inch is the thickness of the spleen. 3 inch is the breadth of the spleen. 5 inch is the length of the spleen. 7 ounce is the weight of the spleen. And 9 to 11, which is present. It is lying deep to the 9 to 11 ribs. What are the external features? We have 2 ends, anterior and posterior, and 3 borders. 2 ends, 3 borders, 2 surfaces. 3 borders, the superior border, inferior border, and intermediate border, and 2 surfaces, that is the diaphragmatic surface and the visceral surface. This visceral surface is the inner surface. So how the spleen lying? Spleen, the axis of the spleen. So spleen is like making an angle of 45 degree with the 10th rib, with the axis of the 10th our vertebrae like this, and the sternum like this. So this is our that sternum part, and that is our vertebrae part, and we have the 10th rib. The axis of the 10th rib is going on like this. So spleen lies parallel to the axis of the 10th rib, which is making a angle of 45 degree. Talking about what are the ends, we have the posterior end. This is the posterior end, and this is the anterior end. Two ends, posterior end and anterior end. This is the superior border. Superior border, just see, it is thin and convex, and it has splenic notches present. Okay, so if you get a spleen to identify, first of all, don't confuse the spleen with the kidney, because in kidney the ureters will be intact, and if not intact, they will be present. Like you should not be confused from identifying a kidney and the spleen. But when you get the spleen, the superior border of spleen, so you'll just look for your splenic notches. The splenic notches is present in the superior border. Then the inferior border, which is smooth and thick and a bit concave. And we have the intermediate border. We have the intermediate border that is present in the splenic hilum. In the hilum of the spleen, this is the intermediate border. And the anterior end, this anterior end is very broad, more like a border, but it is the end. It is broad and faces downwards, forwards, and to the left. Faces downwards, forwards, and to the left, like this. And this is related to your phrenicocholic ligament. We'll talk about this. And your posterior end is like blunt and rounded. Talking about the relations of the visceral surface. So what are the relations? So you can just draw the relations. These are very easy of the visceral surface of the spleen. The visceral surface, okay, where it faces the viscera. So where it faces the viscera, we have our gastric impression here. We have our gastric impression, which is the largest, and it is formed due to the fundus of the stomach. So we have a gastric impression in this part. Then the hilum is present. Hilum is lying on the intermediate border, you can note. And your renal impression. This is the renal impression of the spleen. And then we have below, we have your splenic flexure of colon. So it is called as the colic impression, the green part, colic impression. And this orange one, this orange part is called as a pancreatic impression, for the tail of the pancreas. The tail of the pancreas passes through this part. Tail of the pancreas is seen in this part. And the posterior relations, you have the 9th, 10th, and the 11th rib. Talking about how the spleen is lying, and this is the important clinical thing also. So look, here you have a diaphragm, and here you have the splenic flexure of the colon. Splenic flexure of the colon must be present over here. And then we have a ligament which is connecting the diaphragm from the colon, which is called as the phrenicocholic ligament. Okay, so if you have a splenomegaly, if the spleen increases in size, it will tend to go forwards instead of right and not downwards due to a phrenicocholic ligament. The spleen will tend to go forward like this. It will go forward like this, and it will not go downwards. It can't go downwards due to a phrenicocholic ligament. Arterial supply, what is the arterial supply? So the splenic artery, which is the largest branch of your celiac trunk, we talked about this, remember, in your arterial supply. That's where we discussed the arterial supply first. So we have a splenic artery coming like this, and this is your spleen. The splenic artery is also giving a branch which is called as a short gastric artery. And this ligament which is formed is called as a linorenal ligament, and this ligament which is formed, this is called as a gastrosplenic ligament. So we have a linorenal ligament, and the content of a linorenal ligament will be your splenic artery. In your gastrosplenic ligament, the content will be short gastric artery. Splenic artery divides into 4 to 5 hilar branches. This comes and divides into 4 to 5 hilar branches. We have a compact spleen in which the hilar branches are very short, and if the hilar branches are very long, okay, so we have a diffuse spleen. And what is the venous drainage? Venous drainage, we have the splenic vein. So we have the splenic vein that is running like this, posterior to the spleen, and the splenic artery that is running in the upper part. This is a splenic artery. So splenic vein just runs parallel but posterior. It is present behind the body of the pancreas. What is the axis? This long axis of the spleen. We have the superior segment, we have the inferior segment. So there lies a avascular plane. There lies a avascular plane in the spleen, which can be used for surgical incision. Remember, we talked about the avascular planes when we talked that kidney also. So we have a avascular plane for spleen also, and we have a avascular plane for your liver also. So at the junction of the superior junction and the inferior superior segment and the inferior segment, just perpendicular to the long axis, we have our avascular plane of the spleen. Talking about accessory splenic tissues where it can be found. So in gastrosplenic ligament there may be splenic tissue present, linodenal ligament, and greater omentum, and the broad ligament of the uterus, which is rare. This you can find accessory splenic tissues present developing in this region, which is abnormal. The most commonly ruptured abdominal viscera is the spleen, and the referred pain to the left shoulder. The referred pain is to the left shoulder. So splenic pain is referred to the left shoulder because of irritation of the left diaphragm, and this is called as a Kehr's sign, K-E-H-R, Kehr's sign. So what is Kehr's sign? Because look at this, the spleen. This is a spleen, and due to this irritation of the diaphragm, the referred pain can be to the left shoulder, and this is called as a Kehr's sign. So that completes your spleen. Spleen is like short organ, but it is important. Just revise the notes. Let's move on to the next part. So let's talk about the liver. Liver is the largest endocrine plus your exocrine gland. It's the myxocrine gland, and location is the right hypochondrium, mainly the right hypochondrium, but it extends to the upper epigastrium and the part of your left hypochondrium also. Upper epigastrium and the part of the left hypochondrium also. So note the location. In case of males, we have 1.8 kg, and in case of females, we have 1.4 kg. And 1/40, it comprises of 1/40 of the body's weight. It's contributed by the liver, so it is a huge gland. And 1/18th of the body weight, it's contributed by the liver in intrauterine life, as it is huge in intrauterine life due to hematopoietic features. And then as age progresses, it starts regressing a bit. So liver is wedge shaped. We have our many surfaces and many borders. Let's just see. This is this wedge shaped like a wedge. So we have a superior surface here, and this is our anterior surface. This is our anterior surface. Just take some other color. Okay. This is our anterior surface. We have a superior surface here, and the right lateral surface. Then we have this right lateral surface, anterior surface, superior surface, and then a posterior surface. Posterior surface is present behind. You can see this surface is the posterior surface. Talking about what are the borders, this is the inferior border. This is the inferior border, which is prominent and sharp. You can identify the inferior border of liver easily if you get the cadaveric section. And we have our visceral surface. That is, the visceral surface is present like this. This is the visceral surface, just like present in the in visceral part where the visceral organs start forming. And what are another things? Okay, so this completes your surfaces. And your lateral surface, superior surface, anterior and posterior surfaces, these are called as the diaphragmatic surfaces. The lateral surface, this lateral surface, where's the lateral surface? Yes, the lateral surface, your superior surface, lateral surface, superior surface, the anterior surface, and the posterior surface, excluding your visceral surface. All the surfaces combine to form your diaphragmatic surface of liver, which is partly or fully covered by your diaphragm. Then we have this structure of liver. Right lobe is there, left lobe is there. So this is, we are looking from the anterior view. So we have our falciform ligament, extending falciform ligament lying at the level of left hepatic vein, which is a component of your ventral mesogastrum. And this falciform ligament extends inferiorly as the ligamentum teres, which is the obliterated left umbilical vein. Ligamentum teres is the obliterated left umbilical vein. We have a cystic notch present over here. The cystic notch will be present like this with the gallbladder. Due to the presence of gallbladder, we have an inferior border. This is an inferior border where cystic notch is present, and a notch for ligamentum teres is also there. So we have two components. We have a cystic notch present and the notch for your ligamentum teres in the inferior border. The superior border, we have our only falciform ligament. So this is the diaphragmatic surface of the liver, which you are seeing. Here you can see the coronary ligaments also. These are your coronary ligaments like this. This is the coronary ligament, and this is the left triangular ligament. Then this is a falciform ligament, and it extends posteriorly to form a round ligament, that is the ligamentum teres. So we have a cystic notch present like this, and these are your right lobes and the left lobes. So you can just well appreciate the diagram. It is very easy. Okay, it's very easy. Talking about the posterior inferior view of the liver, this is the posterior inferior view. Just see, first we'll discuss the schematic structure, then we'll come to this part. So this is a posterior inferior view. You can see the posterior inferior view, and here the fissure for ligamentum venosum is present. Fissure for this is left lobe, this is right lobe. So seeing from the posterior view. So here there is a fissure for ligamentum venosum. Ligamentum venosum is the it is present in intrauterine life, and the remnant is the ductus venosus. Okay, so ligamentum venosum, and we have fissure for ligamentum venosum, and this for a fissure for ligamentum teres, and this we have, which is called the porta hepatis. This is a porta hepatis. Ligamentum venosum, ligamentum teres, and your porta hepatis. Then we have the groove for inferior vena cava, and we can well appreciate the 4 lobes with the fossa for gallbladder here also. So we have a left lobe, we have a right lobe, and your caudate lobe and your quadrate lobe. So these are the lobes. Let's talk from this section. Okay, so let's discuss. So we have our impressions also. We'll have our impressions, which we'll see in the visceral relations of the liver. Talking about, let's discuss this first. Okay, so this is our posterior inferior view of the liver. This is our IVC is there, and this is called the Bayer area. This is called as the Bayer area of the liver, which is the avascular plane of the liver. And here you have the gastric renal impression. Here you have the colic impression, colic impression, which is there in the right lobe, and we have the caudate lobe and the quadrate lobe. Okay, so caudate lobe, no impression is there. In the quadrate lobe we have a pyloric impression, and in the left lobe we have our gastric impression, major gastric impression, and the esophageal impression also, So you can just imagine your stomach coming like this and going like this. You can just imagine your stomach, and then your kidneys are present like this. So it is causing a renal impression and a colic impression, like the large intestine will be present like this, the colon, and these are your visceral surfaces, the relations of liver. So after discussing this, let's move to this diagram which we have, the real-time picture. So you can see the liver here, and this is a left triangular ligament which is running like this. This is your right triangular ligament which is running like this. This is a left triangular ligament, this is a right triangular ligament. The right triangular ligament has 2 parts, that is an anterior coronary ligament and a posterior coronary ligament, which are running like this. And this anterior coronary ligament, the posterior coronary ligaments, these are splitting. Okay, and you can say also in transverse manner, as in reverse manner, as the anterior coronary ligament and the posterior coronary ligament, these are fusing to form your right triangular ligament, or you can say it splits. Okay, and it doesn't cover this area of liver. So this area of liver remains uncovered by all the ligaments. So it is called as a Bayer area. And you know, this is a caudate lobe, this is a quadrate lobe. In the quadrate lobe, we have the fossa for the gallbladder. This is the fossa for the gallbladder. Gallbladder is present here. This is the fossa for the IVC, where the IVC is present. And you can see a falciform ligament being lying here. This is a fissure. Okay, this is a fissure for your ligamentum venosum. Okay, and we have our porta hepatis. This part is the porta hepatis, this part is the fossa hepatis, and this is a fissure for your ligamentum teres. Understood? So this is all about your liver. Let's move on. These are all about your liver, visceral relations and all. Let's discuss the surgical divisions of liver. These are surgically very important. Liver is an organ which is surgically very important, because we have to sometimes remove the segments, the surgical segments, and it is asked also in the various exams. You will need PG and all. So it is based upon the Cantilese line. What is the Cantilese line? It is the imaginary line between inferior vena cava and the fundus of the gallbladder. Okay, so this is your inferior vena cava. If you are seeing the liver from your anterior surface, this is your inferior vena cava and this is your gallbladder. So this is the line which is your Cantilese line, and the right lobe and the left lobe division is based upon the Cantilese line. The Cantilese line lies at the level of your middle hepatic vein. Talking about the inferior vena cava, we have our hepatic veins, that is the right hepatic vein draining into IVC, middle hepatic vein draining into IVC, and the left hepatic vein draining into IVC. And this line is your Cantilese line. Understood? And what is the line of your falciform ligament? So falciform ligament lies in the level of your left hepatic vein. So this is the level of your falciform ligament, and this lobe we are if we are discussing the surgical lobes and the anatomical lobes, so they are different. Like the anatomical lobes, these are based upon the level of a falciform ligament. These are based upon the level of your falciform ligament. So if we discuss the anatomical lobe, so here we will have a right lobe and here we will have a left lobe. And if we discuss the surgical lobes, we'll discuss upon the cantilese line, and based on the cantilese line we will have our based on the cantilese line, this cantilese line will be present over here, and so based our right lobe and the left lobe, this whole part. Understood? So this surgical lobe and the anatomical lobes, this differ based upon the lines in which we are talking. Let's discuss about the sectors of the liver. So we have four portal sectors. So first of all, we have your first sector, second sector, third sector, and the fourth sector. So this is the sectors of the liver. And this lobe, these sectors are also surgically taken. Like this is called as a left surgical lobe. This is your cantilese line. This must be a cantilese line, and this is a right lobe. Okay, right surgical lobe. So left surgical lobe. Let's talk about the left surgical lobe. So left surgical, this cantilese line, this middle one is having a first segment. This first segment is lying a bit deep. Okay, so you can understand it is present in a 3D. So it is lying a bit deep. And then your second one is there, third one is there, fourth A is there, fourth B is there, second, third, fourth A, fourth B, like this. It is going like this. You can you can do like this. Okay. Then your fifth is there. After fifth, you go here, sixth, your seventh, and the eighth. Understood? So what happened? Your second, third, fourth, 4A, 4B, fifth, sixth, seventh, eighth. Just understand this pattern. This type of pattern you have to make, or you can just retain the lobes. And this is a right hepatic vein, this is your middle hepatic vein, and this is a left hepatic vein, must be lying, this going must be posteriorly. Okay, this is a falciform ligament. So if you talk about the anatomical lobes, so this is a right anatomical lobe and this is a left anatomical lobe. Let's discuss. This is based upon the Conrad's classification. So Conrad is a scientist who classified the liver surgical classification based upon the hepatic and the portal veins. So we have four portal sectors. That's the right lateral sector, right medial sector, left medial sector, and the left lateral sector, which we discussed. This is your right lateral sector. This is your right lateral sector. Okay, this is your right lateral sector. This is your right medial sector. This is the left medial sector, and this is the left lateral sector. Talking about the segments, we have 8 segments. We have 4 lobes. We have 4 lobes, 4 portals. We have 2 sectors. We have 2 segments. Just discussing about the surgical classification. Let's talk about the surgical classification. What we have 2 segments. Don't say segments. You can say lobes. 2 lobes of liver. That is your left surgical lobe and your right surgical lobe. We have 4 sectors, that is your right lateral, right medial, left medial, and your left lateral. And then you have segments, that is 8 segments. 8 segments are your first segment, okay, first segment, and second segment, your 4A, 4B, your 5th, 6th, 7th, and 8th. Okay, so segments are denoted in Roman numeral from 1 to 8. 8 segments. So this is your surgical classification done by Conrad. Talking about the segments, so right lateral sector, this has the segments 6 and 7, and right medial sector has the segment 5 and 8, and left medial has the segment 1 and 4, and left lateral has the segment 2 and 3. Understood? So this it is classified. The one is also classified as a separate segment. One is present in a caudate lobe, which from the one, it is the bile is drained from the caudate lobe. Just remember, the caudate lobe bile is drained both into your left hepatic duct as well as the right hepatic duct. Your veins. Okay, you can see the first segment. It is present in the culmination point of your RST and your LST. So this is a surgical classification which we talked about earlier. These things you have written. This is the first segment. This is the third, fourth. 1 2 3 1 2 3 4 5 6 7 8. So you are moving in this pattern, you are moving in this manner, you are moving clockwise like this. Understood? Due to left to falciform ligament, the parts of liver left to falciform ligament are removed. Which segments are retained in the left surgical lobe? You can say left surgical lobe. So left to falciform ligament is removed. So let's draw this falciform ligament must be present here, and left to falciform ligament. The left to falciform ligament, these are removed. Okay. So which parts will be like spared? If this part is removed in the left surgical lobe, the parts that are left to the falciform ligament, these are removed. And what is it saying? Left to falciform ligament are removed. Which segments are retained in the left surgical liver? Talking about a left surgical liver, this is a like left part. Okay, here is the left surgical lobe. So left to falciform ligament are removed. So talking about left to falciform ligament, these are removed. So we will have our this parts present in the left surgical left lobe. So this is a left lobe, and here what parts will remain? Your 1 and 4. 1 and 4. So answer is your 1 and 4. Extra points: factors keeping that liver in position are your hepatic veins. Hepatic veins are keeping them in position. The intra-abdominal pressure by abdominal muscles and the ligaments of liver are keeping the liver in position. So that completes your liver. Let's move on to the next. Let's come to the stomach. So stomach is a J-shaped organ. You know about this. It is the most dilated part of your GIT. In barium contrast X-ray, it is imaging technique which is used to view the stomach. So we can have a reverse L-shaped stomach. We can have a J-shaped stomach, a semilunar stomach, or a steer horn shaped stomach. And the steering horn, you can say. Length is 10 inches and capacity is about 1500 to 2000 ml. External features: you have 2 ends, 2 curvatures, 2 surfaces, your cardiac end and pyloric end, your lesser curvature, greater curvature, and 2 surfaces, anterior surface and posterior surface. So what are the parts of the stomach? You can see from here what are the parts. So here we have a cardiac notch. This cardiac notch is present, and this is the cardiac end of the stomach. This is a greater curvature, lesser curvature of the stomach, and here, okay. This is the junction between your body and the pylorus, and this is the pyloric end. Understood? And the cardiac orifice, about the cardiac orifice, this cardiac orifice is 2.5 cm to the left, 2.5 cm to the left of the junction of the left 7th costal cartilage to the sternum, where the cardiac orifice is present, and level is the T11 vertebrae. Your pyloric orifice, it is 1.5 cm right to the medial plane, and the level, this is a pyloric orifice, and the level is at the lower border of L1, transpyloric plane. At the transpyloric plane we have our pyloric orifice, and anatomical pyloric sphincter is present. But in your cardiac orifice, no such sphincter is present, only physiological sphincter is present. Curvatures: lesser curvature where the attachment of lesser omentum is there, and your greater curvature at the left border where there is attachment of this ligaments. Okay, let's first talk about lesser curvature. So lesser curvature is attached to the lesser omentum, and the greater curvature is attached to the gastrophrenic ligament, gastrosplenic ligament, and the greater omentum. This part is attached to a gastrophrenic because the diaphragm will be there now. So gastrophrenic ligament, and spleen will be there, so gastrosplenic ligament, and omentum will be there, greater omentum, so greater omentum will be attached. Greater curvature is attached to 3 points. And what is insula angularis? This is an angular notch, also called as the angular notch, and the most dependent part of the lesser curvature. So basically this insula angularis, this is the angular notch, also called as the angular notch. This is the most dependent part of the lesser curvature, most dependent part. If there is some fluid accumulation of the pus formation, then it is gonna be more chances are there that it will form, accumulate in your insula angularis, as it is gravity dependent. So it is the junction between body and the pylorus part. I told you now, there is a junction between the body and pylorus. This part is called as the insula angularis. Okay. So I've talked on the greater curvature. This is attachment to these 3 ligaments. We told okay, these 2 ligaments and the greater omentum. What are the different parts of the stomach? Different parts. We have the cardiac part, we have the fundus part, body, and the pyloric part. This is the fundus part, this is the cardiac part, this is the body part, it's a huge part, and this is the pyloric part. This fundus part reaches the level of your left 5th intercostal space. This fundus reaches the level of your 5th intercostal space, and gastric pain mimics your angina pectoris due to this. Why the gastric pain mimics your angina pectoris? Because this fundus part, it reaches the level, this reaches the level of your left fifth intercostal space. And fundus looks radiolucent in the X-rays. Fundus has gas filled. As it is gas filled, it looks radiolucent in the X-ray. It is your barium meal X-ray. Okay. Talking about the pyloric part, we have the pyloric antrum 7.5 cm in length, pyloric canal 2.5 cm in length, and the pylorus. Pylorus has how you can identify the pylorus? It has the circular sulcus and location of pre-pyloric vein of Mayo. Pre-pyloric vein of Mayo is present in the pylorus part. We'll see about that. And the pylorus part is the sphincteric part. It is quite thick because of thick layer of your circular muscles are present. And this pyloric canal, this is just above the head and neck and the pancreas. That you can see the pancreas. This is the head and the uncinate process in the neck. So this pyloric canal is just lying on the head of the pancreas, just above the head and neck of the pancreas. And between the pyloric canal and the pyloric antrum, there is the sulcus. It is called as the sulcus intermedius. Sulcus intermedius. Under the peritoneal relations of the stomach, so we have the lesser omentum, the greater omentum, the gastrosplenic and the gastrophrenic ligament. These are the peritoneal relations. And about the visceral relations, let's talk about the anterior relations. So you can just draw the stomach like this and see the anterior relations. So we have the liver here. So the upper part, the part that is your fundus part, the part of fundus, and the cardia part, mainly the cardia part is related to your liver. Which lobe of liver? Left lobe and the caudate lobe. Left lobe and the quadrate lobe. Sorry, not the quadrate lobe. Quadrate lobe is present below, right? And this body part, this major part of the body is related to your diaphragm. This part is related to your diaphragm. The diaphragm must be lying like this. This part is related to your diaphragm, and below the part, this body part, this is related to your anterior abdominal wall. Anterior abdominal wall. Then you have a triangle formed here, which is called as a gastric triangle. How the gastric triangle is formed? The gastric triangle is formed by which is bounded by the inferior border of liver. It is bounded by the inferior border of the liver, this one, and it is bounded by the left costal margin. That is this one. This is the left costal margin, this one, and the transverse colon. The transverse colon, this one. Okay, here you'll see the presence of a transverse colon. Is bounded by the transverse colon. So this is the gastric triangle. Gastric triangle. And in this gastric triangle, what you do, what is important, because gastrectomy, in the removal of the stomach, a tube called a peg tube. This peg tube is put inside this triangle only. It is put inside this triangle only. Understood? So what are the anterior relations? You have a liver, you have a diaphragm, your anterior abdominal wall, your transverse colon, line of transverse colon, and the rib cage, which are forming your anterior relations. Talking about the posterior relations of stomach are called the stomach bed. Okay, posterior. Okay, sorry for the background noise. So posterior relations, we have a stomach bed, and the stomach bed, for mnemonic of the stomach bed, you can say Dr. SSS kills patient mercilessly. Dr. SSS kills patients mercilessly. So this is the stomach bed. D stand for the diaphragm. Diaphragm is in the stomach bed. Dr. SSS. SSS means spleen, the splenic artery, and the splenic flexure of colon. All are related to spleen. SSS means spleen, splenic artery, and the splenic flexure of colon. Stomach bed is very important. It is often asked. And kills. K is for your kidney, left kidney, and the suprarenal gland, which is above the left kidney. P is for your pancreas, and M is for your mesocolon. That is your transverse mesocolon. So let's discuss the stomach bed. These are the posterior relations of the stomach. So we have drawn the stomach in this dotted manner. And what are the structures that are passing? You have your pancreas here. You have the pancreas, that is the first structure. Let's start with the first structure. That is doctor. Doctor stands for D. D is for diaphragm. Where diaphragm, fibers of the diaphragm will be present like this. And then Dr. SSS. SSS means spleen. Here is the spleen. Here is the splenic, here is the spleen, and the splenic artery. Splenic artery must be present like this. Splenic artery present like this, and that is splenic flexure of the colon. This is the colon. So the splenic flexure of the colon, that is also forming a stomach bed. And talking about this, we have our Dr. SSS kills. Kills means your kidney and the related suprarenal gland. So here's the left kidney and the left suprarenal gland. Kills patients. Patients is for your pancreas. This is a pancreas that is present. This is a pancreas that is present in the stomach bed. Mercilessly. Merciless is for transverse mesocolon. Mesocolon, that is for your transverse mesocolon. This is a transverse mesocolon. So this forms your stomach bed. After the stomach bed, let's talk about the interior of the stomach a bit. So here is the stomach. We have the gastric canal. This is a gastric canal, which are rugae are present. Rugae are present, which is called gastric folds, which flatten the distance in relaxed stomach. In your Like when food is not present, this rugae appear, but when the stomach is distended, like this, the rugae disappear. These are your gastric folds, mucosal folds. And we have the gastric pits present with the opening side for the gastric glands. This gastric canal is there, like big rugae. These are also folds which are forming canal-like structures, which are there for rapid passage of liquids. Like flow in this manner. Okay, liquids can flow in this manner due to your gastric canal. Understood? And this gastric canal is most vulnerable to gastric ulcers because it is like transversely present, vertically present, so it is more vulnerable for gastric ulcers. Talking about the arterial supply, we discussed the arterial supply, left gastric artery or right gastric artery, gastroepiploic artery, and the short gastric artery. So left gastric and right gastric this left gastric was arising direct branch of celiac trunk, right gastric was arising from the hepatic artery proper, left gastroepiploic artery and the short gastric artery, these are arising from the splenic arteries. Let's discuss the blood supply of the stomach again. This is a blood supply of the stomach. You can see a celiac trunk, and celiac trunk is giving a splenic artery. Splenic artery is going posteriorly, and we have the other three branches, your pancreatico-duodenal, the pancreatico-duodenal, that magna and all. Okay, these three branches and not much important. And where left gastric artery arising directly from a celiac trunk. This is giving another branch, which is esophageal branches, in giving branches to the esophagus. And the splenic artery, it again divides into a short gastric artery which supplies the fundus part. Short gastric artery supplies the fundus part, and this left gastroepiploic artery is there. From your left gastric artery, splenic artery, and the hepatic artery, okay, there's a common hepatic artery, not a hepatic artery proper, common hepatic artery, and this is the hepatic artery proper. This common hepatic artery and hepatic artery proper, this join to form gastroduodenal artery, which gives a branch that is a supraduodenal artery. This gastroduodenal artery again splits into anterior branch of superior pancreaticoduodenal artery and posterior branch of superior pancreaticoduodenal artery. And this gastroduodenal artery, this gives a branch that is called the right gastroepiploic artery. Understood? So is the blood supply of the stomach. Let's discuss the venous drainage of the stomach. So what is the venous drainage? We have our superior mesenteric vein, and it is pulmonary veins are there. Let's talk in retrograde manner. So we have the left gastroepiploic veins. Here in the place of left gastroepiploic artery, you can just correlate with the arterial supply. The spleen is supplied with a splenic vein. Splenic vein is a part of your pulmonary vein. This pulmonary vein is giving a right gastric vein and a left gastric vein. This left gastric vein and the right gastric vein, it drains into a pulmonary vein. And the superior mesenteric vein is a pulmonary vein and a splenic vein. This splenic vein goes like posteriorly to the stomach and supplies the spleen. The splenic, this right and this short gastric veins and the left gastroepiploic vein drains into a splenic vein. And we have another vein, which is inferior mesenteric vein, which is also a branch of your splenic vein. And the right gastroepiploic vein, it is draining into your superior mesenteric vein. This is a superior mesenteric vein. The right gastroepiploic vein is draining into superior mesenteric vein. There is a vein which is connecting your right gastric vein and the right gastroepiploic vein. This vein is called as a prepyloric vein of Mayo. So this is running in front of the pylorus part, which connects the right gastric vein and the right gastroepiploic vein. Talking about the lymphatic drainage, let's talk about the lymphatic drainage. So you can divide the stomach in this part like 1, then you can do 2. This part is so 2, 3 and the 4. So talking about the 1, this part 1, from this part the lymph is drained into your left gastric nodes, and this left gastric node drain into your celiac node. From this 4 part also, it is drained into hepatic nodes, and this all nodes drain into a celiac node. And 4th part again to the hepatic node, and this hepatic node to the celiac node. From the second part, we will have your right gastroepiploic nodes, and from the third part we have your pancreatico-splenic lymph nodes. So this pancreatico-splenic lymph nodes drain into a right gastroepiploic node, and this right gastroepiploic nodes drain into pyloric nodes. And we can have directly draining the lymph drain into pyloric nodes. You can have directly also. And from this pyloric nodes, this lymph is again drained into hepatic nodes. And the fourth part, it is drained directly into hepatic nodes, and this hepatic node drained into your celiac node. And again this celiac node, so you can see just that celiac node is just a convergence of all these nodes which are draining, and the celiac nodes, it drains via the intestinal lymph trunk, it drains into a cisterna chyli, which is your lymph heart, which drains into your thoracic duct. The cisterna chyli drains into thoracic duct, which drains into the junction of the left subclavian and the left internal jugular vein. Left subclavian, the left internal jugular vein, it is draining into it. In talking about gastric carcinoma, it is commonly occur in the pyloric antrum along the greater curvature. So gastric carcinoma most commonly occurs in the pyloric antrum along the greater curvature. Like cancer cells are like spread by your lymphatic vessels to the supraclavicular lymph nodes. So you can see your supraclavicular left subclavian, the supraclavicular. So the lymph may spread via the lymphatic vessels to the supraclavicular lymph nodes, which is called as a Virchow's node, and the sign is called as a Troisier's sign. So what is Troisier's sign? Troisier's sign is commonly seen in gastric carcinoma, in which the cancer cell via the lymphatic vessels reach up to the supraclavicular lymph nodes. Just you can see your supraclavicular lymph nodes where I have discussed your breast. I had talked about your supraclavicular lymph nodes, which is called as a Virchow's node, and this Virchow's node, this sign where the lymphatic gastric carcinoma cells are present, this is called as a Troisier's sign. This is important. What is the innervation of the stomach? Sympathetic from T6 to T10. Okay, and via the greater splanchnic nerve. What is the function? This sympathetic nerve, this is vasomotor, this is motor to pyloric sphincter, and inhibitory to the rest of the gastric musculature. So pyloric sphincter is contracting, which is preventing the preventing the chyme to reach the duodenum, and it's inhibitory to the rest of gastric musculature, so there is no mixing of food that is going on. So sympathetic, it is generally inhibiting a gastric motility, and sympathetic supplies the chief carrier of a pain for the stomach. And parasympathetic inhibition, we have the anterior vagal trunk and the posterior vagal trunk. We'll discuss about the vagal trunk. This is the anterior vagal trunk. This is lies like this, anterior vagal trunk. These are nerves only, so don't get confused with the color coding. I have drawn the color coding just to show you. So this is the anterior vagal trunk, like this, going like this along the lesser curvature. So it is giving a branch just like this, 1, 2, 3 branches, which are your gastric branches. It is called as a nerve of Latarjet, and a hepatic branch. This is draining into this is a celiac branch, and your pyloric branch is arising from the hepatic branch. So this is the anterior vagal trunk, and in the posterior vagal trunk we have another nerve. Like posterior vagal trunk is coming like this and giving 3 branches. One is called the nerve of Grassi, which is posterior to the stomach. This posterior vagal trunk, so obviously this is posterior to the stomach. Nerve of Grassi, which supplies the fundus part, and nerve of Latarjet, again nerve of Latarjet is present posteriorly also, and we have the celiac branch also. This is a posterior vagal trunk. Okay, so a parasympathetic innervation, your anterior vagal trunk or your anterior gastric nerve or a posterior vagal trunk. So this is the anterior vagal trunk, and this branch is called as a gastric branch or a nerve of Latarjet. Just 3 branches, or you can see the whole branch is called as a nerve of Latarjet. This is a celiac branch, and this is a hepatic branch. From the hepatic branch, your pyloric branch is arising, and in the posterior vagal trunk, you have your nerve of Grassi, your nerve of Latarjet, and your celiac branch. In highly selective vagotomy, not the whole stomach, not the whole vagus nerve, not the whole vagus nerve is removed. Only the in highly selective vagotomy, only this part, this nerve of Latarjet is cut. Why there is nerve of Latarjet cut? Because in this part your parietal cells are more concentrated. So to denervate the parietal cells, we are cutting the nerve of Latarjet only. And this highly if parietal cells are denervated, then HCl won't be secreted and duodenal ulcers will be cured. So highly selective vagotomy is done in which the nerve of Latarjet and duodenal ulcers are treated. So here we complete our stomach. Let's move on to the next. Now let's discuss the duodenum. Please pay attention to this. So I have the first part of duodenum, which is 5 cm long and is present at the level of L1 vertebrae, starting at the level of L1 vertebrae, and it is going a bit up and posteriorly. It is going like posteriorly, and this is the second part. Second part is 7.5 cm long, and the third part is about 10 cm long. It is the longest part, and the fourth part is about 2.5 cm long. Okay. Let's talk about the first part. So first part of the peritoneum, that is initially 2.5 cm is peritoneum, rest of the duodenum is peritoneal. Like the initial 2.5 cm, we talked about this, that the first part of the duodenum, this is not your peritoneum, this is your duodenum. So the first part of the duodenum, the initial 2.5 cm is peritoneal. This is peritoneal. Rest of the duodenum is retroperitoneal, and it is devoid of circular mucous folds or valves of Kerckering. You have read about the valves of Kerckering in your physiology lectures, and this is supplied by the end arteries. It is supplied by the arteries which don't anastomose, the end arteries. What are the relations of the first part of duodenum? So we have to draw a diagram to show the relations. You can draw this diagram. This is the first part of duodenum, and here we'll have your bile duct. This there will be the canal, that will be like you can form this all are your posterior relations. The canal type of structure is formed, like your bile duct that is going to, this is the gallbladder and the bile duct, and the hepatic artery proper. This hepatic artery proper is also coming to the front, and that is a common hepatic artery. This is a common hepatic artery. Then what is going inside is the gastroduodenal artery. Remember, we talked about the gastroduodenal artery. This gastroduodenal artery, it runs like this, and pancreas is present. Pancreas is also present in this part, and these are your relations. So anterior relations, just you have to look and what you have to write. Your gallbladder is there, and the quadrate lobe of liver. What is the quadrate lobe of liver here? Your like this, if there will be liver, okay, there will be liver like this, and the quadrate lobe of liver will be the anterior relation of your duodenum. Then we have the superior relations. Superior relations are your epiploic foramen, and inferior relation are the head and neck of the pancreas. You can know head and neck of the pancreas. And superior relations, we have the epiploic foramen. Remember the epiploic foramen? The epiploic foramen was present in that when we are discussing the peritoneum. We will discuss about the epiploic foramen also, and we also talked there that it will form a superior relation of the first part of duodenum. And posterior relations, posteriorly what are present? Posteriorly you have a portal vein. Remember, portal vein that is going through, this is a portal vein, and your bile duct is going through this, and your gastroduodenal artery. And this gastroduodenal artery, just remember that it can be eroded in duodenal ulcerations. In duodenal ulcerations, this gastroduodenal artery can be eroded. Talking about the relations of second, third and fourth parts, just you have to draw this diagram correctly, and if you can draw this diagram correctly, you can easily write the posterior relations. And about the anterior relations, we'll also see what are the anterior relations and all. We'll see about the first part, second part, and the second part, third part and fourth part, because we have already talked about the first part. Then we'll see the interior of the duodenum and some ligaments and blood vessels. So majorly let's discuss this diagram. So we have your second part, third part and the fourth part, and lying back is your right kidney. Right kidney is there, and from this your renal vein and renal artery must be arising. And this is the inferior vena cava. Inferior vena cava is forming the posterior relation of this part, this second part, and the majorly of this third part of the duodenum. And we have the aorta, the abdominal aorta, just giving a renal arteries, two renal arteries. You know, renal arteries are the direct branch of the abdominal aorta, and this abdominal aorta is also giving two arteries. We talked, remember, these are the gonadal vessels. Okay, these are the gonadal arteries, and gonadal veins will also arise. And this is a right ureter, which will also form the posterior relation of the second part. And of the fourth part, your kidney is there. Your left kidney will form a posterior relation of the second part. And these are your two muscles. What are these two muscles? Your psoas major muscle. So posterior relations, let's talk about the posterior relations. Here in this diagram, we are only showing the posterior relations. To show the posterior relations, that second part is the right kidney, right renal vessels, the edge of the IVC, right psoas major, and the renal pelvis. Very easy. You can just correlate here. Let's talk about this. Okay, this is the second part, and if this is the second part, the posterior relation is formed by the left kidney. This is the right kidney. Sorry, this is the right kidney which is forming the posterior relation. We have the renal pelvis. That means renal pelvis will form the posterior relation. The edge of the IVC, edge of the inferior vena cava, is forming a posterior relation of the second part. And we have the right ureter which is forming the posterior relation. All the renal vessels are forming the posterior relations. And your psoas major muscle, that is lying posterior to this psoas major muscle, are also forming its posterior relations. Let's talk about the second part, third part. Posterior relation the form of the right psoas major, right ureter, IVC, abdominal aorta, and your right gonadal vessels. So we have the right psoas major, which is forming the posterior relation of this part, right psoas major. We have the IVC, that is forming a posterior relation. We have the right gonadal vessels, which are also forming the posterior relation of the second part. And again we have right psoas major, right ureter is also coming like this. You can see right ureter is just it turns a little bit more like this, and it is forming the posterior relation of the third part of the duodenum. And for the second part it is covered. Let's talk about the third part. And we saw that abdominal aorta and IVC both are forming a posterior relations, and the right gonadal vessels I talked, this is also forming the aorta and the IVC. So these are the posterior relations of the third part. And let's talk about the fourth part. So fourth part, you can well observe, this is a left kidney, and if this is a left kidney, it is forming a posterior relation. Then what are forming? Aorta is forming the you can say edge of the aorta, that is forming a posterior relation of this fourth part. And your gonadal vessels, of course, your gonadal vessels, left gonadal vessels. So you can write your left psoas major. Obviously your left psoas major is also forming it. So left psoas major, you can write a left ureter and left gonadal vessels, and you can also write your edge of the aorta. Talking about this, let's discuss the anterior relations now. So talking about the anterior relations of the duodenum, we have duodenum is we may have made the duodenum, the second part and the third part and the fourth part, the second part, third part and fourth part in dotted, and then we have made all the organs like this: the superior mesenteric artery and vein, and our root of mesentery. Understood? So what we have, this is our transverse mesocolon. The root of mesentery is passing like this, and SMA and SMB, then the liver, and we have the colon, the splenic flexure and the hepatic flexure of the colons. So after this, let's discuss what are the anterior relations straight on. So anterior relations of the second part, let's observe the second part. This is the second part, this is the second part. What are the anterior relations? You can say gallbladder, you can say gallbladder, because gallbladder is lying like here, somewhere here. And the right lobe of liver, this is the right lobe of the liver. This is the right lobe of the liver. Then we have transverse colon must be lying somewhere here. And then we have your root coils of small intestine. Coils of small intestine are also present like this. Okay, also present like this. So here we completed our anterior relation second part. Of the third part, we have our root of mesentery. The root of mesentery is crossing the third part. It's not present in the second part. Root of mesentery for the third part. Then your SMA and SMB is superior mesenteric vein and the superior mesenteric artery, and the coils of small intestine. Then for the fourth part, just see, for the fourth part, we have our coils, the coils of small intestine and the large intestine, a transverse colon and a transverse mesocolon. Let's discuss the interior of the abdomen. What is abdomen looks like from the inside. So first of all, we told in the first part only smooth mucous membrane is present, no valves of Kerkering are present. And then we have the second part. Here the second part is there. Talking about the second part, what are the features? So we have this valves of Kerkering that are yellow structures. We have the valves of Kerkering that are present, and we have a minor duodenal papilla which opens 2 cm proximally, and the major duodenal papilla which opens 8 to 10 cm distally, okay, distal to the pylorus. And in this major duodenal papilla, your bile duct, the bile duct opens. This bile duct opens in the major duodenal papilla. After this, we have this minor pancreatic duct, the main pancreatic duct and the minor pancreatic duct. So this main pancreatic duct, of course, it combines with the bile duct and opens, becoming the hepatobiliary duct. This opens in the major duodenal papilla. But the minor bile duct, the accessory bile duct, or you can say the duct of Santorini, it opens in the minor duodenal papilla. And you can see here is a prominent mucus fold. A prominent mucus fold is there, which is called as the monk's hood. And below it, this major duodenal papilla is there. And then we have the tortuous longitudinal fold, which is called as a plica longitudinalis. So you can see all this foregut and midgut. From this major duodenal papilla, from this level, we call it foregut and the midgut. So foregut and midgut we tell with respect to your major duodenal papilla, just at this level. Then what we have, we have a ligament. Look at this. We have the right crus of diaphragm. This must be the diaphragm, and then we have lateral arcuate ligament, the medial arcuate ligament. The diaphragm would be like this. So we have right crus. From the right crus arises a ligament is called as ligament of Treves, and this ligament of Treves connects to the duodenal flexure. Like it is helping to form the duodenojejunal flexure, and this ligament of Treves in the upper 1/3 it is made up of skeletal muscles, middle 1/3 elastic fibers, and lower 1/3 smooth muscles. Skeletal muscles, elastic fibers, smooth muscles, and this ligament of Treves it drags down of the prevent the dragging down of duodenum by the small intestine. Like the small intestine must be dragging onto the duodenum so that duodenum can fall in place, like it can fall down. So it prevents by dragging down on it and forms a duodenojejunal flexure. After that, let's discuss the blood vessels. So of course we have talked about the blood vessels, and let's discuss the blood vessels in a little bit detail. So I told that first part is supplied by end arteries, all the end arteries. So here is our gastroduodenal artery which comes to this part, and this common hepatic artery it gives branches. Then we have the right gastroepiploic artery which supplies half of the second part, this right gastroepiploic artery, and it also supplies the first part as well as the second part, half of its second part, which also divides into your anterior and posterior division of superior pancreaticoduodenal artery. So we talked about this, the gastroduodenal artery. Then we had the supraduodenal artery, which is also called as the supraduodenal artery of Wilkie. Then it was supplying just the upper border, like the upper part. And we have the right gastroepiploic artery which divides in this gastroduodenal artery divides into an anterior and posterior division of a superior pancreaticoduodenal artery. Then we have our superior mesenteric artery which is giving jejunal branches, and it is the first jejunal branch which arises from one of the branches. And we have the branches of superior mesenteric artery. These are anterior and posterior divisions. These both are the anterior posterior divisions of your inferior pancreaticoduodenal artery, which is supplying the third part as well as the other parts. That is the second part, half of the second part, the third part, and this part, okay, fourth part is supplied by your jejunal branches from your superior mesenteric artery. So this was all about your duodenum, all about the blood vessels of duodenum. I will suggest you that you should look at this diagram because it is not very clear in this diagram. I explained you, but chances are you haven't understood. So just refer your book for this, for more details and for the schematic structure, more schematic structure. Understood? Then after duodenum, let's move on to the next. So guys, let's discuss the extrahepatic biliary apparatus, which is comprising of your right and left hepatic ducts. Right hepatic duct, your left hepatic duct. Then your common hepatic duct, which is joined by forming the right and left hepatic duct. We have formed the common hepatic duct, which is 2.5 cm in length. Then the gallbladder, that cystic duct is arising from the gallbladder, which is combining with the common hepatic duct and forming your common bile duct, that is called as the ductus cholecocus. The angle between cystic duct and common hepatic duct is called as a cystohepatic angle. The angle between cystic duct, and the common hepatic duct, this angle, you can see this angle, this let me point out, this angle is called as your cystohepatic angle. Cystohepatic angle. Talking about this, in around 15% of population, we have a accessory hepatic duct also. Accessory hepatic duct which comes from the right lobe of the liver. This accessory hepatic duct comes from the right lobe of the liver. There are many regions where accessory hepatic ducts may be present, like your this part, in your cystic duct, in your gallbladder, or it can be like present in your junction in the common hepatic duct and the cystic duct. The common bile duct, it may be present in the common bile duct, and here if it is present, it is surgically very problematic, okay, because you can very a risk of cutting these ducts. Talk about the gallbladder. Gallbladder is a pear-shaped structure. Capacity is 30 to 50 ml. Function is to store and concentrate the bile. It stores and concentrates your bile. Location in your fossa, that is gallbladder fossa, that is present in the inferior surface of liver. Remember, we discussed about this liver, and we had there is a fossa for your gallbladder. And this upper end, the upper end is related to your porta hepatis. Just you can see the porta hepatis, the impression for porta hepatis. It is like related to the upper end of the gallbladder, or you can say upper end is related to your porta hepatis. and this lower end is related to the right margin of your quadrate lobe. So this is the right margin of the quadrate lobe. Length is 10 cm and width is 3 cm in its widest part. This part is 3 cm, length is your 10 cm, and capacity is 30 to 50 cm. Talking about the parts and relations, we have a body, fundus and neck part. So if you consider this as the gallbladder, then we have the neck part. This is the neck part which is present near the first part of the duodenum. The body part is related to the second part of the duodenum. The fundus part, that is the this body, the junction between body and fundus is the widest part, 3 cm in length, and this fundus part, it is related to your transverse colon. So if you see the sagittal section, this is seen from front, and if you see the sagittal section, you can just appreciate the things. And there is a pouch that is formed. We will see the pouch. Okay, so this is a liver. This must be your gallbladder in the sagittal section, and we have the common right hepatic, left hepatic ducts, common hepatic duct, then the common bile duct present over here, and this is a cystic duct. This must be lined by your peritoneum. This is peritoneum lining. It goes via the liver, and transverse colon is lined completely by peritoneum and all. So after this, let's discuss what is the Hartmann's pouch. Here there is a pouch formed in the neck region. In the neck region, there is a pouch formed, which is called as the Hartmann's pouch. We'll discuss more about the pouch later. If we have any discussions, let me see. Yes, we have the discussions. We'll discuss. So fundus, let's talk about the fundus. So fundus is present at the tip of the right 9th costal cartilage, the transpyloric vein. Okay, the right 9th costal cartilage is present at the tip of it and is completely covered by the peritoneum. You can see the fundus part is completely covered by a peritoneum in this region. Okay, it's completely covered by a peritoneum. It's completely peritoneal. What are the relations? The anterior relation is the anterior abdominal wall. Posterior relation is the transverse colon and transverse mesocolon. You can see the fundus. The anterior relation must be, the anterior abdominal wall must be covering all the viscera, and the posterior relation is the transverse colon and the transverse mesocolon also. Then we have the body. Body is directed upward, backward and to the left. This body is directed upward, backward and to the left. Upward, backward and to the left, like this. It will be directed somewhere like this. And this upper surface of the body is related to a liver. Upper surface of the body, you can see it is related to a liver. Liver must be present somewhere like this. The upper surface is related to a liver, and the lower surface is related to a second part of duodenum and covered with peritoneum. This is related to a second part of the duodenum. You can well appreciate. I told also. And talking about the neck, neck joins with the cystic duct. This neck is joining with the cystic duct. This neck is joining with the cystic duct. Understood? And this neck is joining with the cystic duct. Upper surface is connected to the liver, and the lower surface, it is related to your first part of duodenum. It is observable here. It is related to your first part of the duodenum. And talking about posterior medially, a pouch like dilation is there. A pouch like dilation is present in the neck, which is called the Hartmann's pouch. So if gallstones are lodged here, why it is important? If gallstones are lodged here, then the adhesion of gallstone to the first part of duodenum may occur, and gallstones may even perforate the duodenum. So if gallstones, if they are lodged here, the pouch will dilate and will combine with the first part of duodenum. It can perforate. The gallstones can perforate and go to the first part of duodenum. So it is like important surgically and clinically. Talking about the arterial supply, what is the arterial supply of your extrahepatic biliary apparatus? So here's the arterial supply. We'll have a celiac trunk and the common hepatic artery that was coming. It divides into a hepatic artery, and the hepatic artery has a right branch and a left branch. This right branch and a left branch. From this right branch, we told that cystic artery arises, and it also gives a branch to your this part. To which part is this? Your common hepatic artery. Okay, and then is common hepatic duct. Okay, CHD. Then what I said. Okay, then let's trace other parts like the the celiac trunk is giving another branch, which is a gastroduodenal artery. It's a major contribution to the extrahepatic biliary apparatus. Gastroduodenal artery was dividing into right gastroepiploic, superior pancreaticoduodenal, and this superior pancreaticoduodenal is giving another branch to your common bile duct. This gastroduodenal artery is also giving another branches to the bile duct. Okay, to the bile duct, to the common bile duct. So these are your contributions of and how it is supplied, the artery supply. So common variations of cystic artery may originate from the the cystic artery may the most common very like observation is that it arises from the right branch itself, but it can arise from the hepatic artery proper, or it can arise from the left branch even, in this sequence of preference and this sequence of so most of the individual it is arising from the right branch. Venous drainage is it's by a cystic vein which drains into your portal vein, and the by veins in the fossa of gallbladder also, like hepatic veins, this also drain it. Lymphatic drainage, there is a cystic lymph node of Lund, okay, cystic lymph node of Lund, which is frequently enlarged in the case of your cholecystitis. In case of your cholecystitis, this cystic lymph node of Lund is like frequently enlarged. And the nerve supply is by right phrenic nerve, sympathetic nerve, and the parasympathetic nerves. So right phrenic nerve, this referred pin is to the right shoulder tip, because we told that right phrenic nerve irritates when there is a problem, okay, there is any enlargement or cystitis or your cholecystitis, okay, it will irritate your diaphragm, and the referred pin will go to your right shoulder tip. Sympathetic nerve supplies T7 to T11, parasympathetic is by right and left vagus. And due to this vagus, the pain of gallbladder may be referred to stomach. Okay, so there may be stomach pain, there may be inferior angle of scapular pain due to sympathetic innervation, and due to right phrenic nerve involvement, there can be right shoulder tip pain. Talking about the cystic duct, what is the interior of the cystic duct? Talking about the cystic duct, so mucous membrane lines the cystic duct and present in form of concentric folds. 5 to 10 concentric folds are there, which are called as the spiral valves of Hister. Spiral valve of Hister. These spiral valves keep the duct open all the time. And what are the parts of your bile duct? Talking about this, we have the supraduodenal part, present superior to the duodenum, retroduodenal part which is lying deep to the duodenum, and we have the infraduodenal part as well as the intraduodenal part. A little of the cystic bile duct is like going inside, which is called the intraduodenal part. We have 4 sphincters. Like the bile duct, this bile duct is guarded by a superior and inferior choledochal sphincter, which is called as a sphincter of Boyden. And this main pancreatic duct, it is guarded by another sphincter which is called as the pancreatic sphincter. And this bile duct and the main pancreatic duct, this merge to form an ampulla vater, which is also called the hepatopancreatic ampulla. And this ampulla vater is guarded by a sphincter of Oddi. Ampulla vater is guarded by a sphincter of Oddi. You must have read this in your physiology in 11th standard. And this ampulla vater opens into the major duodenal papilla. So if it is understood, let's move ahead. Let's discuss the cystohepatic triangle of Callot. Okay, we can also tell it Callot's triangle. Let's discuss the Callot's triangle. It is important. So liver is there. This liver is there, and your bile duct is there. This is your gallbladder, and your cystic duct. Then you have the common hepatic duct which is rising. There may be right hepatic, left hepatic, like this. We are showing only the common hepatic duct, and this is the common bile duct. This is the common bile duct which is forming. So there is a triangle formed. This is a triangle formed which is called as the Callot's triangle. So it is formed by the inferior border of the liver. It is from the common hepatic duct, inferior border of liver, common hepatic duct, and the cystic duct. So this 3, inferior border of liver, common hepatic duct, and the cystic duct, are forming a triangle which is called as the cystohepatic triangle of Callot. What are the contents? So we have the right branch of hepatic artery, we have the cystic artery, and the cystic lymph node of Lund. Okay, so we have the right branch of hepatic artery, cystic artery, and the cystic lymph node of Lund. So that completes the extrahepatic biliary apparatus. Let's move on to the next. Let's read about your pancreas. So pancreas is also important. Location is the epigastric region in the left hypocolic region. Okay, pancreas is mainly located in the epigastric region. You can just remember this, and the right hypochondric region also. This is not colic, it's hypochondric. Okay, location T12 to L3 level, and length is 12 to 15 cm. Width is 3 to 4 cm, thickness 1.5 to 2 cm, and weight is 80 to 90 gram or 70 to 80 gram. What are the parts? We have the head, neck, body, and the tail. 4 parts: left, head, neck, body, and the tail. Head contains your uncinate process. You might have observed the pancreas like this, and this part is called as your this part is called as your uncinate process. Neck, body, and the tail. Body has your tubercle omentate, and your tail. So this is about your parts. Let's discuss the parts. So here is our head, duodenum. Okay, here is our head. This is the uncinate process. This is the neck, and there's a projection here in the body which is called as the tuber omental, and the body is there and the tail is there. This is the tail. So head has three borders: superior border, inferior border, and right lateral border. So talking about the head, it has superior border. This is the superior border, which is related to the first part of duodenum. The second border, that's right lateral border. Okay, right lateral border, that is related to the third part. That is related to the third part of duodenum. And we have the inferior border. Inferior border is related to the second part of the duodenum. Okay. So that completes your borders and two surfaces: anterior surface and posterior surface. Anterior surface is related to a transverse colon and transverse mesocolon. Somewhere around this, we will have a transverse colon like this, and transverse mesocolon will be present along with it, just superior to it. And posteriorly, we have the bile duct and left renal vein and the IVC. Left renal vein, your bile duct, and the IVC. So, and the head, relations of your head, you can just observe from this. And okay, so this part is the head. So here what must be present, your as I told in the relations, the anterior border is containing your transverse colon and the transverse mesocolon. This anterior relations is not seen here. Okay, transverse colon and the transverse mesocolon may be present like this, because there is the splenic flexure colon must be lying like this. And afterwards, the posterior relation is the bile duct, left renal vein, and IVC. You can see all these things. You can here bile duct is not drawn. You can see your IVC present over here. You can see the IVC, and your left renal vein may be present. The kidney must be present, and the left renal veins, and these are also present. Okay. Talking about the uncinate process in the head. Anterior relation of uncinate process. This is the anterior relation of uncinate process is the superior mesenteric artery and superior mesenteric vein. Anterior relation, superior mesenteric artery and vein, and the posterior relation is the aorta. Just you can see the posterior relation is the aorta. This is your aorta. This is the aorta which is present posteriorly. Talking about the neck of the pancreas. What is the neck of the pancreas? Anterior relation is the pylorus of the stomach. Here is the neck part. Anterior relation must be the pylorus of the stomach. The pylorus of stomach must be lying somewhere like this. So anterior relation is the pylorus. This is the pylorus part, you know. So anterior relation is the pylorus of the stomach, and the posterior relation is the portal vein commencement. The commencement of your portal vein, which is not seen here. The commencement of the portal vein, it occurs in the neck region posteriorly. Talking about the body of the pancreas, if you take a section of the body, it will appear like triangular like structure. There's three borders, three surfaces. Talking about, this is the anterior surface, this is the posterior surface, and this is the inferior surface. Then the superior border, anterior border, and your inferior border. What are the relations of the border? Superior border, anterior border, inferior border. So superior border is related to a celiac trunk, hepatic artery, and the splenic artery. Superior border is related to a celiac trunk, hepatic artery, and the splenic artery. So you can see superior border is related to a splenic artery. Hepatic artery will be present over here also, and your splenic artery, hepatic artery, and your celiac trunk. Celiac trunk you can see here. Yes, celiac trunk. And then the inferior part is related to your aorta, and the superior mesenteric artery, superior mesenteric vein, these are also related. So and you can see the inferior border, you can write superior mesenteric artery and the superior mesenteric vein. This is artery. And then the anterior border is your transverse mesocolon. Transverse mesocolon must be present like this somewhere anteriorly. So this anterior relation is the transverse mesocolon. And talking about the surfaces, the anterior surface is related to the stomach and the lesser sac. Posterior surface to the aorta, origin of SMA, left kidney, left suprarenal gland, splenic vein. And inferior surface is related to duodenojejunal flexor, splenic flexure of colon. Duodenojejunal flexor and the splenic flexure of colon are present inferiorly. Understood? That completes your relations and surfaces of the body of the pancreas. This is the body of the pancreas. Okay, I was talking about the neck when I was telling this SMA and SMB condition. This is the body, and you can just well note what if you can draw the structure. If you can draw this exact structure, then you can easily write the relations. So just pay attention to the structures. You can take a screenshot if you want. Yes, let's move ahead. Okay, let's talk about the tail. Tail sometimes is severed during splenectomy. So as tail is present in your hilum of the spleen, it is related to a hilum of the spleen. So it is just sometimes severed. Okay, like it cut during the splenectomy. And severed pancreas secretes enzymes leading to severe consequences like sometimes tail is like okay, but if the pancreas is like severe, if it is more severe, then it can cause the hyper release of the hormones, that is insulin, glucagon and all. Okay, will suffer from insulinoma, or your due to more of glycogen secreting, that it depends on which cells are like severe and which islets of Langerhans are affected and all. So it depends. Talking about the tail, it is the only peritoneal part of the pancreas. It is the only peritoneal part, lies in present in the linorenal ligament. Just you can correlate the linorenal ligament. We had that spleen was there and two ligaments were forming, linorenal ligament and gastrosplenic ligament, like this. But structure, right, like spleen was present and two ligaments were attaching like this, and we had this covering. So it told that linorenal ligament, there is a gastrosplenic ligament. Understood? That structure I was talking about. So tail of pancreas is present in the linorenal ligament. It is a mobile tail, and large number of islets of Langerhans are present in the tail. So if tail is severed, then there will be more secretion of hormones. What are the relations related to the hilum of the spleen and present in gastric and the colic impressions? So if in the pancreas, so if the gastric and the colic impressions, so tail is present in the gastric and the colic impressions. Let's discuss the ducts of the pancreas. So the main pancreatic duct, that is called the duct of Wirsung, which joins in the bile duct and opens the major duodenal papilla, we saw just a few minutes ago. And the accessory pancreatic duct is called the duct of Santorini, opens into the minor duodenal papilla. Then we have the arterial supply of the pancreas. So just pay attention to the arterial supply. We have many arterial supplies, many venous drainage, many nerve supplies in the abdomen chapter. So you have to just practice all the diagrams. Here's the celiac trunk, and the celiac trunk is splenic artery is present. This splenic artery gives three branches. Remember we talked about 1, 2 and 3 branches. So this is a dorsal pancreatic artery. One is the dorsal pancreatic artery. This is called as the arteria pancreatica magna, which supplies all the body part. This dorsal pancreatic and the arteria pancreatica magna supply the body part, and the tail is supplied with the arteria chordae pancreatica. Then we have your gastroduodenal artery, which is now supplying the pancreas, and we have the superior pancreatico-duodenal artery, which was giving an anterior branch of superior pancreatico-duodenal, and the posterior branch of superior pancreatico-duodenal, which anastomoses with the superior mesenteric artery, which gives inferior pancreatico-duodenal artery. The superior pancreatico-duodenal and the inferior pancreatico-duodenal, this fuse in this part, this anastomose in this region. The venous drainage is the portal vein, superior mesenteric vein, and the splenic vein. Nerve supply, sympathetic supply, we have T6 to T10 segments, and parasympathetically we have the posterior vagal trunk. That is the right vagal trunk. Remember the right vagal trunk and the left vagal trunk we discussed in the stomach part. Talking about the clinicals, the carcinoma of the head of the pancreas. If there is the carcinoma of the head of the pancreas, so it will produce obstructive jaundice. Why? Because if there is carcinoma, the bile duct and hepatopancreatic ampulla, this is also related to the head of the pancreas. So bile duct will get damaged, get destroyed in the carcinoma and produce obstructive jaundice due to that. Due to cholestasis that will be formed due to this. And pancreatic adenocarcinoma, that's what are the signs: epigastric pain which radiates to the back. Epigastric pain, we talked about this, weight loss and obstructive jaundice. These three signs are the signs of a pancreatic adenocarcinoma. Talking about this, let's discuss the next type. Let's talk about the cecum. Cecum superiorly continues with the ascending colon, medially related to ileocecal junction, posterior medially connected to your appendix. Okay, you can see the cecum like this, and appendix will be projecting out from it posterior medially. What are the types of cecum based on the growth? So you have the fetal type of cecum, that is conical cecum, the shape something like this, and it is a type 1, and 2% of population will have conical cecum throughout their life. It is rare, but it's present in 2% of population. Infantile type, that is a quadrate type of cecum. This is a quadrate type of cecum. This is type 2 and present in about 3% of population. We have right cecal saccule and the left cecal saccule. Normal type, that is type 3, seen in approximately majority, is 80 to 90%. Where the right cecal saccule, it is a little bit bigger than the left cecal saccule. One of the tinea coli present over here, and the terminal ileum must be there. The ileum must be continuing like this. And then you have the exaggerated type, type 4, present in about 4 to 5% of population. Exaggerated type, where the right cecal saccule is very, very big, okay, as compared to your left cecal saccule. and the left cecal saccule you can consider is negligible or absent. It is very big right cecal saccule is present. Let's discuss the relations. So, I have the anterior relation, that is the coil of intestine, greater omentum, and the anterior abdominal wall. You can just relate all these things which are there. The cecum must be present like this, and the large intestine, this is a cecum, and the small intestine will be there. The coils of intestine will be there. The greater omentum will be there of that and covered by the anterior abdominal wall. You can easily write the anterior relation, and posterior relation is called as a cecal bed. Cecal bed. So what are the things that are present posteriorly? So if you consider the cecum like this, then we have the psoas major muscle that will be lying like this, and the genitofemoral nerve must be piercing this, and we have our external iliac artery. We have the right external iliac artery and the right gonadal artery posteriorly, that is going posteriorly. We have this common iliac artery and this external iliac artery. Internal iliac artery is not in your cecal bed, then your cecum is there. Iliacus muscle will be present. Do you remember the structure we discussed, the muscles, and in the lumbar plexus we discussed about how the nerves and all things, the muscles were piercing and going on. And then we have the lateral cutaneous nerve of thigh, femoral nerve. These all are forming a cecal bed. So what we have our psoas major muscle, part of psoas major muscle. We have a iliacus, a lateral cutaneous nerve of thigh. Your femoral nerve is present. The genitofemoral nerve is also present, and the right external iliac artery and the right gonadal artery, which are forming your cecal bed. Let's talk about peritoneal relation. 90% population cecum is completely covered with peritoneum. So we call the cecum as the peritoneal organ, and the space behind the cecum is called as retrocecal space or a retrocecal recess. Retrocecal space or a retrocecal recess, and this is the most common site of your appendix. So let's talk about this. This is a cecum, and this is a terminal ileum, and this is a vermiform appendix. So this fold is this whole space. This whole space is called as the inferior ileocecal recess. This whole space, this from this part, is called as your superior ileocecal recess. So this ileocecal recess or your ileocecal recess or retrocecal recess, talk about this. This is the inferior ileocecal fold, which is bloodless. It's called as a bloodless fold of Travis. Okay, this is called as a bloodless folds of Travis. Okay, this is the bloodless folds of Travis, and this is called the inferior ileocecal fold. Then we have the mesoappendix. The appendix is there. Then the mesoappendix, the peritoneal lining, and the appendicular artery, which will be passing like this. So after discussing this, let's move on to the interior of the cecum. So we have two orifices, that is the ileocecal orifice and the appendicular orifice. So we have our like this. If you have the cecum, then and the terminal ileum. So we have our ileocecal orifice here, ileocecal orifice, where the ileum and the cecum opens like this. It will be opening like this, somewhere like this. Okay, so it is your ileocecal orifice. It is guarded by ileocecal valve, where the upper horizontal lip of ileocecal valve at present the ileocolic junction, and the lower concave lip of ileocecal valve, which is present like this, and this extends as your left cecal frenulum and the right cecal frenulum, and then appendicular orifice, which extends posterior medially and forms an appendix and connects to your appendix. And this appendicular orifice is guarded by a valve of Gerlach. What is the valve of Gerlach? It is guarding. It is the valve which is guarding your appendicular orifice. This orifice is about 2.5 cm in length. What is the blood supply? Blood supply of cecum and the appendix. So you can draw this diagram for the blood supply. So we have the superior mesenteric artery. The superior mesenteric artery is giving an ileocolic artery. This ileocolic artery has a superior division and the inferior division, and we have from the inferior division there will be anterior and posterior cecal branches, and the appendicular artery which will be supplying the appendix, and this is the mesoappendix part. Talking about the venous drainage, which will correspond to the veins, the corresponding veins, the superior mesenteric vein, the portal vein. Lymphatic drainage is the ileocolic lymph nodes. Ileocolic lymph nodes is drained into superior mesenteric lymph nodes or the pre-aortic lymph nodes. Nerve supply is the sympathetic supply is the T11 to L1, and parasympathetic is the both vagus nerve. T11 to L1 sympathetic, both vagus nerve parasympathetic. So that's about cecum. Let's discuss the next part, that is the appendix. Let's discuss the vermiform appendix. So we have plenty of patients if you take the surgical branch. There will be plenty of patients of suffering from appendicitis, and the operation, the laparoscopic methods and all are adopted to diagnose and treat appendicitis. to treat the appendicitis. That is, what is the length of the appendix? So it is 2 cm to 20 cm. Average length is about 9 cm. It is longer in children as compared to adults. The base of appendix is fixed in all, but the apex which is dangling, and the base is posterior medial wall of the cecum, 2 cm below the ileocecal orifice. So if we have the costal margins here, then we have the planes, that is a transtubercular plane and the mid clavicular line. So there is a junction between transclavicular plane and the mid clavicular line where the base of the appendix can be seen. 2 cm distant from this intersection where you will find the base of the appendix. So this is the surface anatomy. Let's discuss in which positions the appendix is commonly present. So let's see that this is a cecum and this is your terminal ileum. So appendix may be present. This is a base which is present 2 cm from your 2 cm distally from the intersection point between the mid clavicular line and the transtubercular plane. The appendix may be present pre-ileally, that is pre-ileal position before the ileum, or it may be present post-ileally. Pre-ileal and post-ileal positions, pre-ileal in 1% and post-ileal in 0.4%, and this is called as the 2 o'clock position. Just you can imagine a clock here, this will be pointing towards 2. So it is called as the 2 o'clock position, very less chances. Then we have the 3 o'clock position. This is also called the promontoric position. 3 o'clock position in less than 1% population it is present. Then we have the pelvic position in 4 o'clock position. It is present in 31 cases. In 31% of cases we have the pelvic position, that is a 4 o'clock position. It is the second most common position. This is 4 o'clock position, and this is present in 31% of cases, which is where it crosses the pelvic brim and reaches till the right uterine tube. Then we have the mid-inguinal position, the 6 o'clock position, vertically downward position, mid-inguinal position in 2% of population. Then we have the paracolic position, that is the 11 o'clock position, which is called as a paracolic position, present in 2% of population. And then we have the retrocolic part, retrocolic, and this is the most common appendix. Retrocolic appendix, the most common position, the 12 o'clock position in 65.5% of your population. Okay. Nerve supply is the sympathetic nerves, T10 segment, and referred pain goes to your umbilicus, and parasympathetic nerve is the both vagus nerve. Sympathetic is the T10 and parasympathetic are the both vagus nerve. Appendicitis, it is the initial pain is referred to the umbilicus, then pain is localized to the right iliac fossa, and then the underlying musculature will undergo spasm. And maximum tenderness is felt as McBurney's point. You get a short note on McBurney's point. So here you are, your ASIS is there, umbilicus is there, and this is a line connecting the ASIS and the umbilicus. Then your inguinal ligament is there. This is a pubic tubercle. So this is a McBurney's point. The point is situated at a distance of 1/3 in ratio format, 1/3 from ASIS and 2/3 from the umbilicus. So there's a point which is called as a McBurney's point. To check the presence of appendicitis, we have two tests, psoas test and your obturator test. This is a psoas test. Which is done for a retrocolic appendix, where pain is felt in this gluteus maximus region. Pain is felt. And the obturator sign, if you just do like this, if the leg is taken in this format, the leg is taken in this manner, then pain will be occurring at this gluteus maximus region. And the psoas sign will confirm the presence of a retrocolic appendix. And obturator sign, if you just turn the leg, if you just laterally turn the leg, flexing, and if you just do the internal rotation of the thigh, you can see internal rotation of the thigh and flexing and doing internal rotation of the thigh, then pain will be localized to the lateral part of your knee. Okay, and this is for your pelvic appendix. So you have the two tests. If there is in the most common appendix are your pelvic appendix, you can say your pelvic position 31% of cases, and your retrocolic position in your 65% of cases. So we have this two tests. If there is retrocolic appendicitis, then psoas test will be positive, and if there is pelvic appendicitis, you have to do the both test, as you don't know in which individual which type of appendix is present. So this completes the vermiform appendix, and now we come to the end of the chapter. So that's all from my side. I hope you enjoyed the lecture. and let's meet again in some any other video of anatomy. So that completes the whole abdomen, and we completed the abdomen in about maybe it's 3 hours 30 minutes or so. So let's meet in any other lecture, and if you like the lecture, do like, share and subscribe. Thank you and goodbye.